Hey everyone, welcome to the Drive Podcast. I'm your host, Peter Attia. Hey Stephen, thank you so much for coming over. As we were talking about, I don't really do many of these in person anymore, often just out of sheer laziness, but I do enjoy it a lot more. So the fact that I know it was a bit of a hassle, you had to probably change clinic or something today, but anyway, really appreciate you coming out. And this is a topic that, I think everybody has questions on this topic,
right?
And everybody, myself included, is comically ignorant on this topic. I mentioned to you a few minutes ago the extent of my knowledge from medical school. I remember there's an optic nerve. I remember it's a cranial nerve. I think it's even the second cranial nerve.
There you go. You're ahead of the game.
I remember something called a fovea.
Right.
And I know there's a blind spot, but I've kind of forgotten why. So it's safe to say my knowledge of this topic right now is probably at par with everybody's, right?
Well, that's, not rare, frankly, because the eye is so literally compartmentalized. We just don't interact that much with other specialties. So it's not rare for people who are in other specialties to be very ignorant of the eyeball. And that's fine, because I think it'll help us keep the level of discussion at an approachable level for everyone.
Has there ever been a discussion about suggesting that ophthalmologists don't need to do the 4-year MD degree? Like, how much of what you learned in medical school became relevant in your residency?
Actually, quite a lot, honestly. Yeah, because you think about it, the eyeball, there's really nothing specifically magical about the eyeball. It's got neurological tissue in the back, actual brain tissue in the back. It's got a vascular supply. There are a lot of crossovers to other medical disciplines. All of the cellular processes are the same. We operate adjacent to the eye. I think it's important for us to have a general sense of medical knowledge, particularly because so many systemic diseases manifest as eye problems. Now, there is a discipline of medical training or of visual training, basically optometry,
yes,
which deals with the eye, but not all of the surgical stuff. So we work in a collaborative fashion with optometrists, and those are the folks who are fitting glasses, they're screening for eye disease, they're handling preoperative and postoperative care in many cases, they're treating some diseases that are specific to the eye, like glaucoma, for example, and we work in a collaborative fashion with them.
And does everyone in an ophthalmology residency spend time operating? There's no non-surgical discipline to this, right? It doesn't bifurcate in the training?
Well, it does, actually. There are non-surgical ophthalmologists, but I think they all start out as surgeons. To become an ophthalmologist, you're really training to become an eye surgeon. Mm-hmm. But there are, for example, neuro-ophthalmologists, which are really more neurologists than eye surgeons. In fact, it's typical that they don't do eye surgery. So there are some ophthalmologists who don't do eye surgery.
One of my sort of lasting memories from residency was stealing suture from the ophthalmology OR at Hopkins, because I guess for people who don't know, the number of the suture, of course, gets larger, the suture gets smaller. So right. An O suture is like, you can see how thick it is. It's like a piece of rope.
Right.
1O, 2O, 3O. By the time you're at 4O, it's actually quite thin.
Right. We use 11O.
Exactly. In cardiac surgery, you're using a 7O.
Yeah.
Occasionally, there's some guys that would sew the distal end of a coronary artery with an 8O. And at that level, it's already very thin. I mean, just the slightest tug too much and it breaks.
Right.
But then in ophthalmology, you guys were at 11O. And so I used to steal 11O constantly every night I was on call and practice suturing with 11O.
Right.
The thinking being, if you can tie an 11O with your hands and not tear it, that 7O, which normally is like a piece of hair, is going to feel like a piece of rope. So I used it to help me develop a good feel for fine suture. But then I also realized I'm kind of being a schmuck here. I bet this 11O stuff's really expensive, and I'm just stealing it like there's taking it to the call room all night.
More likely it was probably 10O, but yes, our tools are little tiny tools. And I can remember our operating room when I was in training was sort of near the orthopedic surgery
The exact
area.
opposite,
And you
right?
hear this Black & Decker stuff going on over there. And our little tiny tools are it's just a totally different.
Is everything you do under a microscope operationally? Like you don't operate with a naked eye, right?
Right.
Yeah.
I mean, right. It's all under a microscope. Either, just to put it in a visual for people who may not be familiar, we have a binocular microscope. So I'm looking through both eyes, and this is either mounted from the ceiling and is controlled by my feet. So the X, Y, and Z and the zoom focus are controlled by a foot pedal. And that either comes from the ceiling or it's on a really large stand. And so I'm sort of I'm looking straight ahead, but so the image is here, but I'm operating down here. And it's interesting because sometimes my wife will kid me. I'll come home from a day of surgery exhausted, but she says something like, well, I don't really get it. You're just sitting in a chair, sort of making these little tiny movements, and there's soft music playing. It all seems very, very sedate. It's incredibly stressful and exhausting. You do that.
Although I will say, in your wife's defense,
Yeah.
she has it harder because of the kids. So
Yeah, that's true. For sure. Let there be no misunderstanding about that. It's way easier.
Well, actually, I never really thought about that. But the other advantage you have is you don't have that cervical flexion problem that most surgeons have when they're in an open. I mean, nowadays with more robotic and laparoscopic surgery,
that's right,
you can be in an advantage neck position. But
we have a different problem though, and that is that people tend to, and I don't want to mess up the sound and microphone, but they tend to hyperextend. They tend to bring their head forward to come up to the oculars.
Yeah.
And that creates a whole other set of problems.
Yep.
So there are ergonomic challenges for sure. And I remember early on in my career, I was coached very carefully on how to sit, how to have your spine arranged. Don't crane your neck forward.
Yeah.
And make sure that your shoulders are down. It's interesting because when you train surgeons and you look at them, they're all sort of raising their shoulders up and they're terrified that they're going to do something wrong. So they're in a very, very compromised and stressful position. And then they tend to lift their hands up. So they're actually, and again, I mentioned earlier that these are little tiny movements. So very small positional changes can have a huge impact on the outcome of the surgery.
Yeah, I have a number of friends, two in particular from residency, who have had multiple neck surgeries, including one that required such significant extent of fusion that he could no longer operate. So he trained as a cardiac surgeon and now does cardiac critical care. So still a great career, but after 10 years of training as a cardiac surgeon, can't operate anymore.
Yeah, I mean, surgery, it takes a toll on the surgeon for sure.
So when you went to medical school, did you know you wanted to do ophthalmology?
Not really. I think I knew I wanted to do something surgical. I wanted to do something with my hands. I'd kind of always been good with my hands, and I could draw reasonably well. And you get, as you kind of know, you get feedback early on in your medical career. If you demonstrate that you're decent with your hands, people say, hey, you're pretty good with your hands. You should think about something surgical, or maybe not. They say, have you thought about radiology or something along those lines? And so I kind of knew that I wanted to be a surgeon, but really didn't know what type. And I remember a eureka moment where the first time I looked through what we refer to as a slit lamp, which is basically like a microscope to look into the eye. The very first time I looked through that instrument at an eyeball, I was hooked. I knew this is what I wanted to do.
And that was something you did during an ophthalmology rotation, or were you doing an ER rotation and somebody came in with something stuck in their eye?
It was during an ophthalmology rotation, and I'd had some exposure to ophthalmology because a friend of mine's father was an ophthalmologist, quite a famous one. And I'd had a background in photography when I was a little kid, so I kind of understood optics well. But that was during one of those 1 week, do a little ophthalmology, do a little ear, nose, and throat, do a little bit of whatever it is. And that was a nice thing about medicine, is that you kind of get to taste a little bit of everything before you decide you're going down a particular pathway.
So It's funny, I didn't really overlap with ophthalmologists. So you guys didn't do a general surgery internship, I'm guessing, right?
Some of us do that. I
really?
did what is referred to as a transitional residence internship, where you do a little bit of everything. You do general surgery, internal medicine. You do a little bit of everything. That's very helpful. And the general surgery part, I will confess, that was rough. I mean, as you well know, but it was nice to have exposure to a little bit of everything.
So it's probably a 4-year residency, I'm guessing?
When you include the internship, that's right.
Yeah. And back in the day when you did it, what was the bread and butter? You always kind of judge a discipline by what the bread and butter is of the era, right? So general surgery, if you did it in the 1960s and 1970s, the bread and butter would have been Bill Roth procedures and things like that, where, the most common thing you were doing was cutting out half of the stomach because of peptic ulcer disease and things like that. By the time I got to residency, I never did one of those, right? Because, H2 blockers and PPIs basically eliminated the need to surgically remove part of the stomach for gastric or peptic ulcers. So at the time you went through your training, what was kind of where did 80% of the volume come from? What type of cases?
Yeah, still cataracts. Okay. Cataract surgery, and then retinal disease, the scourge of essentially diabetes, where you had these very, very complex retinal problems. So those were really the two main ones.
So that's probably a good moment to sort of take a step back and get into some of the anatomy and get me up to speed, and everybody else by extension, on what it is we are talking about here. Because even the word retina, cornea, these are I kind of know the retina's at the back of the eye. That it's just embarrassing, Stephen, how much of a Luddite I am when it comes to this part of the body. So I can say this, literally talk to me like I'm a 4-year-old.
Okay.
And explain the eye to me.
That's good. That'll work for both of us. So, it's funny you mentioned that, because I don't typically see kids in my practice, but there is one disease state where I do see kids. And that's because we did some research in that area that, anyway, allows me to see kids. And when you explain the eye to a kid and you say, well, the eye is like a camera and the film in the back, that's the retina. And they look over at their parents like, what is this guy? What is this guy talking about?
Isn't a camera the thing on your phone?
What is he talking about? Film? What is that? A 50-year-old understands that, but literally the eye is kind of built like a camera, where in the very front you have the cornea, which is kind of like the covering on the front of a watch. That's the thing that a contact lens would sit on. Okay. And then the next thing you encounter is the pupil, which is the hole in the iris. Behind that is the lens. We refer to it as the lens, but it's really one of a couple of different lenses inside the eye. But the lens behind the pupil, then you have the vitreous cavity, and then in the very back, the retina, which attaches to the optic nerve, and that's what goes to the brain. So images come in, they're bent by the cornea first, then bent again by the lens, and then they focus hopefully on the retina. So in a perfectly sized eye, in someone who doesn't need spectacles to see, images come from, say, optical infinity, which is, for the purposes of our discussion, about 20 feet or beyond, where light rays come in parallel, and they're bent so that they fall perfectly on the retina.
And what does that mean, fall perfectly on the retina? Meaning they is the if you think about the back of the eye here,
right?
What fraction of the back of this sphere is considered retina?
All of it.
Everything.
Yeah, all of it. The whole back of the eye is coated essentially by retina. But there is the fovea you mentioned earlier. That's the point where you cast your gaze. So the image of the thing you're looking at falls on the fovea, which is the very center, the bullseye, literally, of the retina. So when I'm looking at you, images from you are falling on the fovea of both of my retinas. Now, if someone is nearsighted, those images come into focus in a point that is not exactly on the retina. And so that can become a problem.
And nearsighted, again, the way I used to remember this, because this is literally how little I know. Nearsighted means you see things near well.
Yes, that's right.
And those are people like me who need either glasses or contact lenses to see things at a distance.
Correct. So this is, typical cocktail party banter. Someone will say, I think I'm nearsighted, or maybe I'm both nearsighted and farsighted. So nearsighted means you see better up close. Mm-hmm. Farsighted is a little trickier because farsighted people see better at far, but their far might also be kind of blurry. It's just that the near vision is even worse.
So that person who says I'm near and farsighted that's an accurate statement. That's a plausible pathology?
It's actually probably that they're what we refer to as presbyopic, which is that they see well far away, but their focusing ability is compromised typically through age, and they can't see up close. And we'll get into that.
I want to get to that in detail because I experienced that a few years ago in a manner that rocked my world because it didn't happen gradually.
Yeah,
it seemed to happen overnight.
That's so. It's funny you say that. Some people wake up on their 40th birthday and they say, "I just can't see up close anymore," and for others, it's a little more gradual process. But the reason that comes into play is that when we are young, when we're born, the lens of our eye is extremely elastic. It's like a gummy bear, and it can change shape to bring near objects into focus. But as we age, and this is universal, the elasticity of the lens goes down, and we're no longer able to sort of zoom focus in, and you have to start pushing things farther and farther away, or get some sort of optical aid like a pair of spectacles to see up close. That process continues as the lens becomes less elastic and harder, eventually resulting in a cataract, where it begins to lose its optical clarity. So now you have a lens that's stiff, hard, and starts to become opaque. Mm. So that's kind of
so a cataract is a disease of the lens.
Correct.
And it's a natural, I guess this is kind of a gray area. Do we consider this to be a natural product of aging, the way our skin wrinkles and the elasticity changes? Or is it considered a pathology in the way that type 2 diabetes is a pathology, not necessarily a normal consequence of aging that can be avoided?
Yeah, that's a really good and interesting way to look at it. So I think that cataract formation is a universal component of, DOE, days on Earth. Just I don't recall seeing many people in their 70s without some degree of cataract formation. It starts to become universal. However, there are things that can pathologically, prematurely cause cataract formation. Some of them are sort of surprising, like being electrocuted can actually cause premature cataract formation, but that's one sort of exotic, weird one. But trauma, head trauma, can certainly do it.
Just head trauma, not necessarily eye trauma. Just
the head.
I mean, obviously they go hand in hand. Yeah.
Typically, the eye is in the head, and if the head receives trauma, there's going to be a certain amount of trauma in the eye itself. So
right, but point is, it doesn't have to be direct trauma to the eye. Simply the counter coup forces of the brain are presumably also being reverberated through the vitreous fluid.
That's exactly right. So if you think about, the eye as a fluid containing organ, and when it receives trauma, and just as you mentioned with coup and contra coup injuries of the brain inside the skull, I think those same forces come to bear on the eye itself. So I think it's more common when you do have direct eye trauma, but I think even head trauma alone can predispose someone to cataract formation. Certainly diabetes is a cause of premature cataract formation. Corticosteroid use can lead to cataract formation.
So is the lens a vascular structure?
No, it is not. And the protein, if you think about the lens, it's kind of the shape and about the size of an M&M candy. Just like a plain
chocolate ones.
Yeah, the chocolate ones, right?
Yeah.
You know, just the ones without the nuts or pretzels or whatever they're putting inside M&Ms now. But the you know, a plain M&M candy.
Yep.
And it's got a coating kind of like the candy shell. And the protein inside the chocolate is optically clear when you are a kid. And that protein does not turn over or exchange. But the membrane, the candy coating, the so-called lens capsule, can allow molecules to diffuse in and out. So a classic example of this is someone will point out, hey, you know, my vision, my glasses prescription suddenly changed. I became much more nearsighted, or I became much more farsighted in the space of a month. And I went to the eye doctor and they said, wow, your glasses are totally wrong. And the first thing I think of is go get your blood sugar checked, because glucose can diffuse into the lens, cause it to swell. And that will change the shape of the lens. The lens becomes physically bigger.
Sure.
So it's like a thicker, more powerful lens.
So it's an osmotic change.
Correct.
Basically.
And the time frame for that to happen is over a period of several weeks. So if the blood sugar goes up, there may be a lag of a month or two before the vision changes. And when the blood sugar goes down, same thing. It takes weeks for that to kind of go back to normal.
So again, I'm almost struggling to organize my thinking around this. But the other thing that comes to my mind when you think about an avascular structure is what is the immune system's behavior around the eye? Are these immune privileged sites? Are they more or less susceptible to certain types of infections? Systemic infections, that is. Obviously, I know we'll probably talk a little bit about sort of local infections, but
yeah, I mean, the eye itself is certainly prone to damage from systemic infection. There is a blood-retinal barrier in the same way that there's a blood-brain barrier that protects that highly metabolically active retina from systemic disease. But the lens itself is relatively privileged from an immune standpoint. It's within that capsule, and it's hard for large molecules to get across that. Small molecules can. And that's why
that's going to be important from a pharmacotherapy standpoint. I'm sure
it is. And for example, there is a technology. There's a medication that is a lipoic acid choline ester that is being examined as a way of softening the lens to maybe break some of the disulfide bonds that become a problem and become one of the reasons why the elasticity of the lens is lost.
So you're saying there might be a day when there's either a topical or injectable substrate that could go into the lens that could delay the onset of farsightedness.
And the onset of cataract. That's the hope. This is sort of, at the moment, it's a little bit of a pipe dream because it's in the early experimental phase, but human trials have begun to look at the lens softening properties of this particular compound. The trick is you've got to use it in a topical fashion. So putting in an eye drop, and that drop has to run the gauntlet of going through the cornea, which has lipid layers and water soluble layers. It's got to get through all that into the aqueous humor in the front, and then through the lens capsule into the lens to actually do its work. And that's why it's that particular drug or compound is a choline ester, because that allows it to get through the lipid layer in the front, through the aqueous, through the water soluble portion of the cornea, and then hopefully into the lens itself. And that's not easy to do. So the lens is a relatively privileged area, both from an immunological, but also a pharmacological standpoint.
Yeah, so that would help. That would helps it also
stay clean, clear.
Yeah,
you want the lens to be optically clear.
Let's go back to a little bit of the front of the eye. So the pupil we all recognize is the dark part,
right?
And we talk about the dilation and constriction of the pupil. Is the pupil itself actually changing in size, or is it just that the iris is moving? The colored part of the eye is dilation means it's actually moving back, and constriction means it's actually closing.
That is correct. The physical aperture changes in size. It gets bigger, it gets smaller. So when you go to the eye doctor and they dilate your pupils, they are physically opening up the pupil pharmacologically. And that's mostly so we can see into the back of the eye.
And you do that by forcing the iris to move out of the way?
Correct. The iris has it almost looks like the aperture of a camera.
Yeah.
And so you can either constrict it or you can make it bigger. And interestingly, one of the big pharmacological, I think, frontiers that we're on the cusp of seeing are drugs that intentionally shrink the aperture in the pursuit of increased depth of focus. So students of photography will know that the smaller the aperture, the smaller the hole, the more stuff is in focus at the same time. So if you can make the pupil small pharmacologically and get it into the sweet spot, which is probably about 1.6 millimeters, you can suddenly see up close again, because you've expanded the depth of focus.
Wait, let me make sure I understand this.
Yeah.
You're saying that putting the lens aside for a moment, which is a great source of the pathology, the inability of the lens to move in and out on call it the Z-axis, if we want to think of it that way. You now have another way to manipulate your ability to see things close up if you could force the aperture to be in a position that isn't necessarily dictated by the availability of light?
That's exactly right. So imagine it's kind of like squinting.
Yeah.
If you squint, you're reducing the aperture through which you're looking, and you're filtering out optically. What's happening is you're filtering out all of the light rays that are not perfectly parallel. And if you can get rid of those scattering rays that make the image blurry and only use those parallel rays that happen to be coming parallel off of an object, you can actually resolve it. You can actually see it. And that's why pharmacologically, if you shrink the pupil, you could once again see up close.
Now, this is a little counterintuitive to me, because anybody who's in my shoes, who's experiencing farsightedness, or I shouldn't say that,
presbyopia,
knows that nothing makes it worse than darkness.
Correct.
And so you're in that rest. There's two scenarios where it wreaks havoc. The first is one of my children has a train book that why these guys wrote a book in like 6-point font that they know parents are going to read their kids in bed when it's kind of dark. It's beyond me. There should be a mandatory 24-point font for nighttime books for little kids. But anyway, he's got this one book, and he even tells me before he wants that book read, he's like, "Daddy, go get your glasses."
Right.
And then the other place is the restaurant, where it's usually poorly lit. But in both of those situations, isn't my aperture narrowed? Because no, of course not. It's the opposite. Yeah.
So if you put the sun on something, you're going to be able to read it because your pupil.
So is that why light makes it different?
Some of it is just absolutely, it's pupil effect alone.
I never
and
thought
some
of
of it is just the light. There's much more light energy available for you to resolve something. So yes, there are competing forces. When you reduce the size of the aperture, you're letting less light in, but the only light you're letting in are those rays that happen to be parallel in perfect focus, and you can actually see. So in the clinical trial that we performed to look at this, those competing forces were examined very closely. And we found that the aperture effect, the depth of focus, outweighed any loss of vision from loss of light.
And how long would these eye drops stay in effect? How long would they be able to maintain after you put them in?
I think it depends a little bit upon eye color, believe it or not, because
something I want to ask about in a moment. So I'm glad you brought that up.
Yeah, a certain eye color, like light eyes, tend to react more to any given strength of dilating drop or constricting. But about 6 to 8 hours, maybe up to 10 hours. So this would be a once a day, maybe a twice a day eye drop.
And would this have any impact? Would it compromise your far vision?
Quite the contrary. What was really interesting is that when we looked at patients who had their pupil size reduced pharmacologically, their distance vision also gets better by the same principle because their depth of focus is so good. So in the same way that you can squint and make out a highway sign, if you're a little bit nearsighted or a little bit farsighted or have astigmatism, which we haven't even talked about yet.
Which I don't even know what that is, even though I have one.
That's right. And squinting makes that better. By the same token, the pharmacological manipulation of your pupil will do that as well. And by the way, I think you will see in early 2022 commercial availability of the first of these drugs.
So going back to the more complicated drug you were talking about that it's complicated because it has to make its way into the lens.
That's right.
I can now see why that would be more about the cataract issue and not about the presbyopia issue, because this would be a much easier way to solve presbyopia because you only have to basically get onto the iris.
Yeah, well, you're looking at a drug that shrinks the pupil and works in 15 minutes versus something that softens the lens that might work in 15 months.
Yeah.
So I think they're very different markets. And while that lipoic acid cholinester is being pursued as a presbyopia near vision aid or something to reduce the effects of, I think their real goal is to reduce the incidence or delay the onset of cataract formation, which would be really cool.
Yeah. Is there any clear evolutionary explanation for why different eye colors have emerged? What's the advantage of brown iris versus blue?
Yeah, it's protection from UV light and from visible light. And in the same way, the different skin tones have emerged. So typically you see dark-eyed
people closer to the equator.
Clustered closer to the equator because, the visible light and UV light and infrared light or infrared radiation are really destructive. And as you might remember, this is one of the few things that people remember from medical school about the retina, but it's one of the most metabolically active tissues in the body, if not the most metabolically active tissue. And because it's constantly being bombarded with radiation effectively, it's prone to free radical formation. So what's called the retinal pigment epithelium, which is the pigmented layer behind the retina, underneath the retina, that is responsible for shielding the vascular supply behind the retina from all of this radiation, because that vascular network behind the retina has a very high oxygen tension, and it would be prone to free radical formation if it were constantly being bombarded by UV light, infrared radiation, visible light. And that's why you see in people near the equator more pigment. And that's also true of the iris as well.
So the other thing I do remember vaguely from medical school is rods and cones.
Yeah.
And of course, I also remember a few other things now that we're talking about it, about, where which part of the brain actually does the signal processing and stuff.
Yeah.
So let's go back to the light hitting. And what are the rods and cones and how are they processing that signal?
Right. So, you might remember cones are primarily for your daytime vision, and they're clustered in the center of your visual sphere. So in the center of near the center of what we refer to as the macula, which is the central portion of the retina, and the very center of the macula is the fovea. Right. So that's primarily where the cones are. The rods are in the periphery, and they typically are responsible more for dim illumination vision, like night vision, and they're very good at picking up motion. So, as predators, we want to make sure that we can hone in on where prey is, but as prey ourselves, we want to be able to detect, oh, that's some kind of a tiger over there. Something's moving in my periphery. I need to be aware of that. So that's primarily the difference in responsibility.
And is each rod and each cone, what is it? Is each one a single cell?
Yes, that's right. They're each highly specialized cells.
Obviously, they have mitochondria. Obviously, they have. What distinguishes them? Do they have photoreceptors? Like what makes them unique?
They refer to as photoreceptors.
Okay.
And they have stacks of structures within them that are photosensitive, and that causes a depolarization,
so they work like channel opsins do?
They
use a photon to create an action potential? Or
correct. Once the photon hits that particular cell photoreceptor, then there's a change in the membrane and ions flow, and that's how a signal is generated.
Wow.
Yeah.
Okay. So all of that ion flow ultimately makes its way to the optic nerve?
Correct. That's right. And to the brain. And most of the visual processing is in the very back of your brain. So that's, and about half of the overall brain structure deals with vision in some capacity. And that's why, for example, when people have a stroke, there's almost always some component of visual involvement in a stroke. So you may have a droopy face on one side, and then a limb is droopy as well. But if you map out the visual sphere, you will detect some deficit in the visual sphere from most strokes.
Now, people who listen to this podcast we've on various episodes, we've got into the brain, and people understand that I think there's sort of the brain stem, the most, primitive piece of our brain that is basically responsible for autonomic function. You then have sort of this midbrain that sits on top of it that we call the sort of reptilian brain, a lot of emotion there. But of course, what in theory distinguishes us from all the other animals is this remarkable cortical piece that sits on top of it. And how much of the visual processing is in that neocortex? Is it virtually all done there? Is any part of it done in the midbrain?
Yeah, stuff like pupil responses.
The autonomic stuff.
The autonomic stuff, those are in the midbrain. But the visual processing and the actual mapping of the visual sphere, and even as hierarchical as parts of the brain that are specific to edge detection or moving edge detection, or edges that move this way or that way, that's all been mapped quite elegantly, and it's in the cortex.
Is there a cross?
Yes.
Is the left doing the right and vice versa?
That's right. But remember, you send information from your left visual sphere to the right side of the brain, but you're getting information
this is the trick.
Both eyes.
Yeah.
So both eyes, yeah.
Explain how that works, because I remember in med school needing to draw this a few times.
How long do you have? It's the simplest way to think about something is that at the pituitary, there is something called the optic chiasm. You probably remember, where the optic nerves cross. Right. Some of the about half the fibers cross. So if a visual deficit is in one eye only, we know that it is in front of the chiasm. Correct. Right. And if it's behind that, it should affect both eyes, maybe asymmetrically, but it should affect both eyes. And that can be very helpful in localizing where a particular problem is. Now, a lot of that's done through imaging, but it used to be there was quite an art
to this clinical
exam, which, sadly, we've lost a lot of.
Yeah, and I do remember both in neurology and probably neuroanatomy, kind of going into these really crazy tests that you'd see the patient performing the test and missing a certain thing, and you'd think they must be faking it. Like, there's no way you could produce such a bizarre deficit in this one part of this one visual field. But then of course you see, and look, there's a tumor, and it totally explains this once you understand how the nerves cross.
It kind of goes back to one of your earliest questions, which is, do you think that eye surgeons need to go to medical school? Yes, because we diagnose brain tumors. We find things that are systemic diseases that have ocular manifestations.
So you're obviously well aware that your brother and I are close friends, and he's become pretty obsessed with hunting now. And I'll take full responsibility, at least for the part of it.
I did not see this one coming.
Yeah. Well, you'll see where this is going, right? So he's become super obsessed with hunting. And one of the things that hunting teaches you is how we stack up to wild animals, right? So if you're out hunting an elk or an axis deer or one of these remarkable creatures,
right,
especially with a bow and arrow.
Yeah, I was going to say, how much technology do we have access to in this hypothetical scenario?
So no, let's talk about bow and arrow hunting, where you really, I mean, if you really want to reduce the margin of error, you want to be inside of 50 yards to be able to take that shot.
Sure.
So the way I always talk about this is animals have superpowers, and we just have to decide, as do we have superpowers, our greatest one being our intelligence, which allowed us to make the bow.
Right.
But I generally think of the three big senses, right? Which is the sense of vision, the sense of smell, the sense of hearing. And there's simply no comparison in sense of smell. We basically can't smell. We're effectively useless creatures.
Agreed.
In nature. Yeah. They can smell us if they're downwind of us, they can smell us a mile away, literally 1 mile away. If the wind moves from you to them, they're gone. You'll never get close to them.
Right.
It turns out that the closest sense we have to our prey is vision.
Right.
It's the only thing where we're almost on par with them. Now, there are some animals that can see better than us. There are certain types of rams that if you break skyline within 2 miles of them, they'll see it.
And birds.
Yeah. But for the most part, like this is the one sense that we have that rivals the best.
Right.
Is that because we both had to, as you said, be hunters and be hunted for such a large part of our evolution? This is sort of teleologic explanation I'm looking for, but.
Well, I think so, but just think about this for a moment. Imagine you are in the desert and there is a single candle a mile away from you and it's pitch black. There's no moon. You can see that. But at high noon in that same desert where there may be 200,000 lux illumination, you can still function and see well. So many orders of magnitude of change of illumination. Like, it's astonishing that you can function in both of those environments.
Well, that's actually interesting that you make that point, because as it gets darker, we do tend to have an advantage over some of the animals. Now, it turns out to be very short-lived. There's a very narrow window at dusk and dawn where I think we can outsee them. And maybe that's the benefit we have, in that we evolved slightly better to have this greater range, if you will. But I've always been amazed at, like, why did we not develop a sense of smell? I mean, because we effectively can't smell compared to animals. I mean, it's really absurd how different it is. And I don't know why evolution didn't push that harder.
And even our hearing, I think, is, we're not even
nothing
close
compared to them.
Yeah. But vision, and if you ask, it's very common for patients to grab my arm as we're going into surgery and they'll say, Dr. Dell, you don't understand. My vision is really important to me. I've got to see.
Yeah.
And I get that. It's the one sense that if you asked people which sense they'd be most willing to give up,
it's the
least.
That's
the
right.
very
This is the
last
one.
Yeah. And
in COVID, we saw many people at least transiently lose a sense of smell and a sense of taste. And of course it's inconvenient, but it's totally survivable.
Yeah. It's hard to function in the world as a blind person. And, it's a fear that many of us have. So, it's a sense that we value very highly, and also evolutionarily it's valued highly, just owing to the fact that so much of our brain is devoted to vision.
Yeah, this is a little bit off track, but maybe good for a PSA. When I was a kid, we did so many dumb things without ever any concern for our eyes. I just don't think our parents knew enough, and we didn't think about it. So I'd be out in the backyard chucking things around, cutting wood, smashing rocks, never a thought to put on safety goggles. And now my kids, who are both completely obsessed with cutting down trees and they're very active outdoors. I mean, they just know, like, you're wearing your safety goggles if you do that stuff, because I'm totally paranoid they're going to, have one of these tragic accidents.
Yeah.
do you see much of that stuff? I mean, do we?
For sure. And you see a lot of eye injuries. I think injuries are one of the main causes of devastating visual loss in young people.
Mm-hmm.
If you take visual loss in general, almost all of the big causes and movers of visual loss are senescence related, they're age related. But in terms of vision loss in young people, it's a lot of trauma. And
what are the most common traumas that you see?
I think
like, is it
unrestrained
object
passenger
flying into eye, or is it more?
I think it's more blunt trauma, frankly.
Okay, wow.
Yeah, more blunt trauma. The eye is pretty well protected with the brow and the cheek, but there are certain things that can get in there and can directly impact the eye. And so I think, in a young person, trauma is something you have to certainly watch out for.
What is the velocity at which we can't outblink it? Because the other day my son was smashing beads and he didn't want to put his safety goggles on. And I was like, look, buddy, you got to get these things on. And he goes, no, Dad. And he's like, why? And I said, because you're hitting sharp objects with a sharp object. If one of them flies up and hits your eye, he goes, I would see it and I would close my eyes. And
no,
like,
you wouldn't,
buddy.
Yeah, let's just put it this way. Those objects are flying at supersonic speed and you can't blink that fast.
So do we have a sense of like what our reaction time is to blink?
That is known, but I've long since forgotten what that is.
Because you get the sense like if somebody's throwing you a ball,
that's right,
and you misjudge it, you're going to blink. Like that's slow enough that you can catch it. But then there's other objects where you can't.
Interestingly, I've operated on a number of Major League Baseball players, and for them, seeing the laces on the ball as hitters is enormous.
It's their career.
It is their career. And it's the difference between them hitting, well or average. And some of these players that we've operated on have been 20/20 before they had surgery, but they wanted to be 2015 or 2010. And what that means is, again, here's another nomenclature issue. What is 20/20 vision? 20/20 simply means that you can see at 20 feet what a quote unquote normal person can see at 20 feet. If you're 20/10, you can see at 20 feet what a normal person has to get 10 feet up to in order to see. So 20/10 is better than 20/20. So some of these guys want to be 20/10 or 20, whatever it is, 20/15. We've been able to achieve that with modern forms of laser vision correction because—
Wait a minute. Isn't this now getting into the performance enhancing side of things? Isn't this kind of amazing? I never even
it's
thought
interesting.
Of this.
Yeah, for sure. And I had a discussion yesterday with a guy who owns a soccer team. And I said, have you ever had your players tested for their vision? And he sort of froze and turned white for a second. He just said, it's so crazy you say that because we put them through this barrage of tests physically to see what their heart, their lungs, their kidneys, all that stuff. We didn't check their vision. And there are ways to boost human performance beyond 20/20. The theoretical limit of how well you could see is defined by essentially the pixelation of your retina, the spacing of the cells of those photoreceptors that we talked about earlier.
Does that vary from person to person?
It has to, but it's somewhere in the vicinity of about 20/08 or so. And so if you can have a sharp enough image, you could theoretically see better than 20/10. And the only way you can really achieve that is to remove some of the optical irregularities that we are all born with and somehow neutralize them along with the glasses prescription. And we can actually do that with laser vision correction currently.
So why would it be beneficial? I guess we'll talk about laser surgery and maybe you'll want to park this question until then.
Yeah.
Why would it be beneficial to an athlete who, for understandable reasons, needs the best vision possible to undergo laser corrective surgery versus just using contact lenses to accomplish the same thing? Is that possible?
Yeah. So if you think about contact lenses, anyone who's ever worn contact lenses knows that when you put in a brand new pair of contact lenses, you can see pretty well with them. And then you begin to regard that contact lens as a foreign object. So your body just begins to attack it, coat it with all sorts of immunological debris. You are susceptible to pollen, dust, whatever it is that coats this formerly pristine object. And let's say there is correction for astigmatism in that contact lens, where its orientation is important. Every time you blink, that contact lens moves a little bit. All of those factors contribute to optical performance that is less than what you could achieve with spectacles or laser vision correction. So particularly soft contact lenses do a very, very good job, but they don't give you superhuman vision performance typically.
It's funny. I experimented 2 years ago with a stronger prescription than normal,
right,
to get me to 20/15 in my dominant eye for archery.
Sure. Goofed up your near though.
That's the problem. I just abandoned it immediately after like 6 months of suffering because it made my presbyopia worse.
Yes.
So I was just like, this just isn't worth it.
Yeah, that's right. Yeah. That's the challenge when you pull the image farther and farther away, you're doing the same thing with the near image as well.
So let's now talk about how to correct these. Oh, I guess let's define an astigmatism, since I don't know what that is yet.
Yeah, I mean, it's when the eye is shaped like a football instead of a basketball.
And when you say the eye, which part of the eye specifically?
The cornea, the very front part of the eye typically.
And how thick is the cornea, by the way?
It's about as thick as a credit card, like 500 microns.
Oh, that's thick.
Yeah. Okay. Yeah, like 550 microns, something like that.
So 0.5 millimeter.
Yeah, exactly right. So 0.5 millimeter. And it's typically that is the location of astigmatism. There can be astigmatism in the lens itself, the lens behind the pupil.
You probably don't remember which one I have, do you?
I do.
Which one do I have?
You have corneal astigmatism.
That's the
normal one. Yeah, it's very pedestrian. You're a very boring patient. But
so meaning, just to be clear, I'm not perfectly shaped spherical around here. I'm a bit oblong.
That's right. Shaped like an egg or a football, an American football, right? Okay. So it's if you're walking along the laces of the football, you would encounter a fairly gradual curve. But if you took a right turn and walked perpendicular, it would be very steep.
Okay.
And so that means that the power differs by meridian.
Yep.
So you need a different glasses prescription in this meridian versus this meridian.
And what's the prevalence of this?
It's very high. I think, 60 some odd % of patients with glasses prescription have some significant degree of astigmatism.
Why has poor vision, or I was going to say, why has poor vision been allowed to evolve? I was going to offer that maybe really poor vision hasn't, right? Vision that would impair your ability to survive through reproductive age probably didn't evolve. Maybe there was a day when the genetic variability of eyes was broad enough that a subset of people had really poor vision. The type of people today who maybe we don't encounter.
Right. This is a super interesting topic, and it shows you how plastic the evolutionary or the adaptive component of the eyeball is itself. So the length of the eye is really what determines whether you are nearsighted or farsighted.
When you say length, you mean distance from
front to back.
Okay.
So anterior, posterior length of the eyeball. Primarily, that is the main driver as to whether you are nearsighted or farsighted. Those who are in the know and are watching this or listening to it also realize that sometimes it's the curvature of the cornea that contributes to whether someone is nearsighted or farsighted. But let's say, for the purposes of this discussion, that it's the length of the eyeball that is the main reason why someone is nearsighted or not, or farsighted. So a very nearsighted person has a very long eyeball.
Let me make sure I understand that.
Okay.
Very long AP axis.
Mm-hmm.
You're going to have a real hard time seeing things far away.
Correct.
And is that because the further something is, the harder you have a time focusing all that light?
Well, let's talk about the genesis of this.
Okay.
Right. So if most of your work, most of your visual environment is close, then the light rays from that close object are diverging. And so they are falling behind the retina of someone who's perfectly targeted for distance. So your eyeball is really smart, and it says, okay, so you're telling me everything is here, close up. I know, I'll just grow longer so that these near objects are in perfect focus. And that is exactly what happens.
Over what time scale?
Over a period of months. So if you take a young person and you exclusively have them perform near tasks, their eye will grow longer so that those near objects are in perfect focus.
So if you could do an awful experiment,
it's been
you
done.
would take a child and not put them in a white room where there's nothing that they can see that's far away, and just have them play with close objects that they can reach.
Yeah.
And you would put that kid into glasses as a child.
That's called society in 2021, is children looking at screens, near objects for hours on end and not going outside. There are two drivers of nearsightedness in the plastic developing human. Number one, deprivation from outdoor light. And number two, near work. So, for example, there have been cohorts of children. Most of these studies have been done in Asia, where there is an epidemic right now of myopia of astonishing proportions. I'm talking about 90% of the population is now nearsighted in certain Southeastern Asian cities. When that becomes such a dominant phenotype, something is really oddly off. So,
wow, so this really transcends evolution, because you can change, if you can change something in years or months.
It's not evolutionary. It's within the eye. It's adaptive within the eyeball itself. So if you take a group of children, and this has been done, 7 to 11-year-old children, and you send half of them outside for 80 minutes during the school day for recess, and half of them stay inside in an indoor environment for their recess, the risk of, or the incidence of nearsightedness is 50% higher, or it's half in the group that went outside. So you cut your risk in half by going outside. Now, we think that
without any instruction to go and look at things far away, but just by the very fact that if you're outside, there's so much more to see, and you're going to be looking further out.
Right. And this has been further studied in terms of, is it just being outside, or is it the light?
Yeah.
It's actually both, but the light is really the most important driver of protection from nearsightedness. So if you are outside on a bright sunny day, you're releasing a fair bit of dopamine from your retina, and dopamine inhibits the growth of the eye. So the worst thing you could do is stay inside in a dimly lit room and perform near tasks. That raises your risk of nearsightedness 16-fold compared to kids who go outside.
I'm sure there's epidemiology that would suggest that the further you are from the equator, does that imply that you have a greater risk of nearsightedness just based on the light part of this argument?
Yes, there is some data to look at that. That shows that. And not only that, they've taken children and given them equal intervals of outdoor activity, but the ones who had noontime outdoor activity did better than the ones who were outdoors at 8 a.m., where there was less illumination. And we know from animal models that it is illumination that is critical in this dopamine release. So, does that mean we need more skylights in classrooms or more windows? We need more natural light. Could we artificially mimic some of the sunlight by making these rooms brighter and prevent some of this myopia epidemic?
Is a photon a photon a photon? I mean, does it,
I don't think that it's known, frankly, Peter, whether that's the case, because there's a whole spectrum of light. So is the blue light more important? This is tangential, and we'll talk about this, I know, but blue light, you hear all this negativity about blue light. Blue light is critical for wakefulness, for attention, I think for preventing myopia. And by the way, when we say myopia, nearsightedness, it's not just the inconvenience of wearing glasses or contact lenses or having laser vision correction when you're 23 years old. There are pathologies that are much more common in very nearsighted patients compared to the general population. It's much more common to see cataract formation in myopic patients. They get something called myopic macular degeneration. They're at risk for glaucoma. They're at risk for tears and detachments of the retina. So it's not just the inconvenience of spectacles. These are disease-associated conditions.
So going back to my evolutionary question, it's quite possible that over hundreds of millions of years, any deficit in vision that would have prevented you from reproducing or impaired your ability to escape prey would have taken that out. So from a genetic standpoint, our vision should be very good.
And in non-literate societies, it typically was. So if you look at hunter-gatherer tribes, there is no nearsightedness. There are no Kalahari Bushmen with spectacles. It just doesn't happen.
This is amazing. This suggests that because my parents wore glasses, I should wear glasses is not true.
Well,
is there an epigenetic part of this where it can...
both. There is a genetic component. And if you look at siblings of individuals who wear spectacles, there is a higher incidence of myopia or hyperopia.
But that could be susceptibility, right?
It could be susceptibility.
And then the environmental trigger is what's going to do it in anyone?
And we don't know whether parents of reading children were reading children themselves. So, it's hard to separate out the genetic component, but there does seem to be a genetic component as well. But the environmental component seems to be way stronger and more powerful. So if you take parents who don't wear spectacles and you put their child in a dark room and give them an electronic device or a book or whatever it is, and have that child focus it near for hours on end, odds are they're much more at risk for developing nearsightedness.
So when I just think about this through the lens of my kids, so my wife has perfect vision. I don't. What is my diopter? I think I'm -3 and -4.
That's about right. Yeah.
So what does that mean in terms of the 20 scale? I'm 20.
You're probably like, it depends on how much you squint and look at the eye chart. We honestly don't really attach a lot of significance to the 20/100 or 20/80, whatever it is. You're probably in that ballpark, 20/100 maybe.
But I'm clearly at the point where without contacts, I can't drive. I can't do anything.
Right.
I mean, I'm not as bad. I know some people who, are a -15. They literally can't. They have to put glasses near the bedside.
That's right.
I'll spend the first hour of the day without contact
lenses. That's right. Because you could probably, things are
it's easier for me to read without my contacts.
Things for you are very well in focus at a typical normal reading distance.
Right.
So your eyes have been tuned like postnatally for near work. That's in your development. You must have spent a lot of time reading or doing near tasks.
Well, that's the thing I was thinking about. It's like I grew up in Canada, so from a light perspective, it wasn't so great. You had 2 months of no light whatsoever. But I mean, I didn't watch TV much as a kid, maybe 30 minutes a day.
Right.
I was mostly outdoors. So I don't know how much of it, but I also didn't, I'll tell you, this is funny. I didn't need my first pair of glasses till college. So it could also be that this happened later in my life as a result of more book work.
For sure. So the classic example is we see law students who have great vision when they enter law school, and then they read for 12 hours a day, and then they come in and they say, I think my vision's going.
Yeah.
And you look at them and sure enough, they've become nearsighted. And that's not rare in many graduate school situations where there's just grinding reading for hours on end.
So when I think about our kids, because now I just think, well, what can I? It's too late for me, right? But so
get them outside.
So they are. So fortunately, they live outside.
Yeah.
But when they're inside, they're obsessed with like playing with Legos and trains and trucks, and I mean, that's near, right? So is it that, hey, there's nothing wrong with that, but you just have to make sure they're spending a couple hours outside a day?
I think the data would suggest that good illumination would be helpful as opposed to poor illumination.
Okay.
But you don't want to discourage near activities because those are really important developmental.
Now, is the flip true? So you mentioned that hunter-gatherers or illiterate societies who are out by definition outside all the time,
right?
There's no such thing as nearsightedness in them. Do they develop farsightedness?
Not really. I think that they are fairly well tuned, if we want to use that term, to distance vision, to prey hunting and things like that. So distance vision is very well tuned. Now, there's a whole host of other problems that come into play. Once you've outlived your genetic usefulness, you've reproduced and you've imparted your knowledge onto the next generation, you can go ahead and get cataracts because you're done, genetically useful. Your utility.
So the cataract is sort of like atherosclerosis, if functionally, which is it's the one thing that really has no bearing on your reproductive capacity, but is otherwise inevitable to our species.
It seems to be fairly inevitable to our species. And as I mentioned earlier, I just haven't seen patients in their 70s typically that don't have some cataract formation. Now, there are patients who are 80 that are still functioning with cataracts, but the optical clarity of their lenses has degraded to the point that it's not the way it was when they were 20. Maybe their visual needs are significantly reduced at that age. But if you took an 80-year-old lens and you'd put it in a 20-year-old person, they would be shocked at how poor their vision is.
That's really interesting. Now, earlier you mentioned that we think that senescent cells, or at least the soluble secretory products of senescent cells, are probably playing a role in this.
Well, I think in the lens, it's mostly that the lens proteins are degrading or becoming damaged over time, maybe with UV light, because we know light exposure is certainly related to cataract formation, as are some of the other things that I mentioned, like glucose going into the lens, corticosteroid use. We don't know what it is specifically about trauma that causes a premature, loss of clarity of the lens proteins.
The trauma one's got me worried because I boxed for so long. I took way too many hits to the head. I hope that doesn't come back to, I'm worried about that for other reasons.
Let's just put it this way. The cataract would be the easiest thing to fix.
Yeah.
Cataract surgery today is like a 4 or 5 minute procedure, and it's astonishingly effective.
How often does one need to repeat that surgery?
Cataract surgery typically is not repeated. It's a once in a lifetime deal.
So and what you're noticing is like you're wearing glasses that are dirty. Is that effectively what the patient with cataract is experiencing?
I think the first thing they notice is probably changes in their night vision, glare, halos, streaks around, streaks off of lights at night, problems with contrast sensitivity for those who can appreciate that loss of contrast. Those are really early signs of cataract formation.
So then the patient comes to you, they're 74 years old, or let's say it's sooner. They're 70 years old.
More like 64 or 54, yeah.
Okay, and you're telling them, hey, Billy, you've got cataracts.
Right.
We're going to just ride this out until you tell me you've had enough?
Yeah, typically we let the patient decide when it's the right time for them to have the surgery. Once we determine that the cataract is visually significant. There are people who elect to have their cataracts removed earlier than they really need them removed as a means of getting rid of their glasses prescription. Because now the lenses, the implant lenses that we put in to replace the cataract have advanced in function to the point that they can fix the near vision as well as the distance vision, as the astigmatism, the nearsightedness, the farsightedness, the presbyopia, all those things that we've been talking about, they're all correctable with artificial lenses that we put in the eye to replace the cataract.
Wow. But earlier when you talked about during your residency, the bread and butter was one of the pieces of bread and butter of your practice would have been cataract surgery.
Right.
That didn't involve intraocular lenses.
No, it did. It did. And there's a fascinating history about the evolution of intraocular lenses. But back in those days, the implant lenses that were put in were simply designed to give the patient good vision with spectacles, just to replace the cloudy lens with something that was in the ballpark of good distance vision.
Sorry, I need to take a step back because
Yep.
I'm actually kind of confused.
Right.
Does all cataract surgery involve the placement of an extra lens?
Yes, that's correct. We all, there are exceptions to nitpickers who will listen to this, but virtually every cataract surgery that we perform involves the removal of the cataract and replacing it with an artificial lens.
Does that mean, again, you'll have to pardon my ignorance,
Yeah.
does that mean removing the entire lens or removing a diseased part of the lens that has a
So
cataract?
remember our analogy of the M&M candy?
Yes.
So we leave
leave the shell?
Right. We open a hole in the front of the shell.
Yes.
We take out all the chocolate.
Yep.
And then we have a kind of like a flattened bowl. Looks like a Japanese teapot.
Yes.
Flattened. And we put the implant lens in that bowl. And that holds the implant in place.
And is it a viscous fluid that gets hardened, or is it a hard object that goes directly in?
It's actually a bendable plastic object. And the bendability of it
Is what allows it to get in.
allows us to fold it up and put it through a tiny incision, and then it opens up. So that was a very big advancement.
When did that happen?
1980s was when that began to become.
What happened before this?
So this is a really amazing series of stories, but I'll abbreviate them in the interests of time. But in the old days, like in the ancient world, if you had cataracts, the way they dealt with it is that they would just poke the lens of the eye backward and it would drop down into the bottom of the eye so that you now had a clear optical pathway again to let light in. And this took someone who was functionally blind and allowed them to see shapes. So that was better than...
Right, because you don't have a lens, so there's no way you can focus.
You can't focus. All you can see are shapes.
But it's basically like taking someone who has no light transmission and saying, we're going to let unfocused light go through.
Right. So, it's, some light's better than no light. So that's what happened in, Hammurabi time. So
amazing that I'm always amazed.
For sure.
We look at that now and we say that's barbaric.
Yeah.
The fact that they knew enough to do that is kind of amazing.
Well, they probably tried everything else first, and that
presumably
was the one that
they probably dissected cadaveric lenses and tried to figure this out.
Yeah, and there have been artifacts uncovered that I think a lot of them were made out of gold, but they would take a gold needle and poke it through the cornea, and then it was called couching, the procedure. They would just poke the lens and it would detach from its ligamentous attachments and then drop down into the bottom of the cavity of the eye. And you see some of these artifacts from Egypt. This was done in China. It was certainly done in ancient Greece. That was how you dealt with cataracts back then.
By the way, it's just worth pausing for a moment to reflect. If you're talking about the pharaohs, you're talking about what, 5,000 years ago, right? This is not in an evolutionary timescale. That's a pittance, right?
My profession is an old one.
And you think like it would be better to be the poorest person on earth today than to be the pharaoh of Egypt 5,000 years ago.
I think in many ways,
or certainly it would be better to be in the bottom 10 percentile economically today than the top 10 percentile 5,000 years ago. If the best you have to your cataracts is some guy sticking a hot poker in your eye.
That's right. So then you fast forward to right after World War II, and there's an ophthalmologist in the UK named Harold Ridley. And he notices that some of the RAF fighters would have fragments of their canopy, their plexiglass canopy, shatter when they were fired upon, and these things would actually get inside the eyeballs. Shards of plexiglass essentially would be inside the eyeball. And the dilemma was, well, what do we do with this? And he learned very early on that these fragments were biologically inert, that the eye was perfectly happy and people could walk around the rest of their lives with plexiglass inside their eyeball. And that's a shard of sharp plexiglass. So, and this is one of those.
And this is in part because the lens is so immune privileged. This is
Well, this is a foreign object that has now entered the eye, not necessarily in the human lens. It might even be in the vitreous cavity or in the front of the eye. But
so there was something about sharp plexiglass that
it's something about plexiglass. So the light bulb goes off that, wait, you can put plexiglass, which is essentially polymethyl methacrylate, you can put that in the eye and the body doesn't really care that it's there, doesn't mount an immune response. So in Ridley's book, which I've read, it's really amazing, but some intern asked him, well, when you take this cataract out, are you going to replace it with a new lens? And he looked at this young intern in a very British fashion, I'm assuming, and just said, that's the stupidest question I've ever heard. And then he went home and thought, wait a minute, that's brilliant. We should replace it. And then they lathed a lens from some spectacle maker that was about the size and shape of the human lens. And they actually threw 8 of these in patients. And there's amazing footage of I think one of the first operations, they dropped the lens on the floor. And of course, it's the only one they had. So they pick it up and rinse it off. And they it's fine. They put it in, and these patients did like shockingly well. And this was viewed as heresy. And there was, 20 years of you're blinding people. But eventually the technology won out and it became,
so there were bad outcomes, presumably?
I think in the early days, for sure. There must have been, for sure. And there were. But like any new technology, the first iteration of it is probably terrible and maybe just a little bit less terrible than the alternative. And now it's a ubiquitously used.
So I never thought, because basically I didn't realize until you said it that polymethyl methacrylate is all over the body in terms of joints. Like, and you do when you replace a knee joint, right, the tibial plateau, I think, is made out of polymethyl methacrylate. So presumably there's something about it that is just invisible to the immune system.
Well, we don't use that material anymore because it's stiff. It is not deformable.
Right.
So you had to, in the old days, you had to make a fairly large incision to get get
this thing in.
First of all, to get the cataract out, and then to get the implant lens in. 2 converging technologies made that go away. The number one was we were able to take the cataract out through a tiny incision.
Because you break it in situ?
We break it up. We emulsify it essentially with ultrasound. Or now we even sometimes use a femtosecond laser to break up parts of it. But the bottom line is that we can remove the cataract through about a 2-something millimeter incision, which is very small, like the thickness of a pencil lead, basically. And we can now take these implant lenses and fold them up and put them through that same tiny incision, and then they can open up and be exactly where you want them to be. Now, why is it important for the incision to be small? Well, if you make a big incision, obviously it takes longer to heal, but it induces astigmatism. So you want the incision to be tiny.
So does the using your M&M analogy, does the coating on the surface of the M&M grow back?
No, it does not.
So it's fixed. Whatever hole you put in there, they're stuck with.
Yeah, it's fixed. Now, sometimes the coating, the M&M candy shell, can begin to opacify after surgery. And we can treat that in the office with a laser where we can just disrupt that coating.
So this has got to be like, my mom's 72nd birthday is today. I don't know if she's had any issues with cataracts, but if not, she's due for them.
Yeah.
Right. My dad he's 83. Trying to think, he must have had surgery then by now, right?
There's no way. Yeah, odds are.
So I can't believe I've never really talked about this with him, but it must be a game changer for a patient to come out of the clinic or the OR wherever these, do you do this you have an OR in your office?
We do, but cataract surgery we do in an ambulatory surgery center. But, it may be that your dad didn't talk about it because it was such a non-event. You go in for cataract surgery and the next day you're kind of back to your regular activities.
Right, but wouldn't it have been a big event in terms of his ability to see?
For sure. Especially now that the implant lenses can correct the near vision and the distance vision. So that, in addition to the added clarity from just removing the cataract, patients typically have this benefit of not needing spectacles.
So this is a procedure we should all be looking forward to when it comes. Like
I don't know if I would go that far. I mean, it's still surgery. There are risks associated with it.
What are the biggest risks?
I think that the number one thing we think about is infection, but it's extraordinarily unusual to see an infection.
What's the rate?
Less than 1 in 10,000 cases where you'll see a serious infection. It's like any other surgery in the body. You look for bleeding, damage to the inside of the eye. You have to keep tabs on the pressure. It's basically everything that you would look for if you were taking out an appendix, you're also dealing with in the eye.
What fraction of patients do not have a material improvement in their vision or have some deterioration of even another subset of vision? So yes, you've taken away my cataract. I can see better in the sense of clarity, but oh my God, I became abjectly nearsighted as a result of it.
Yeah, I think that's pretty unusual because the science behind getting the prescription correct or very close to correct is pretty advanced.
And tell me what that entails. So if I came in right now and I had a cataract,
right?
What are you assessing microscopically to make it so I'm getting the impression not everybody gets the same lens.
No, they do not. And some of these lenses are expensive, and they involve the patient having to pay some extra money to get it.
And more money gets you what?
I mean, I think the more money people pay, the more spectacle independence they get. In terms of optical quality, all the lenses are.
How much does a lens cost? Or pair, I guess, since you're doing both.
I mean, I'm the wrong person to ask, honestly. I don't even know.
But directionally, like if somebody has to pay out of pocket for one of these.
If they're getting just like regular cataract surgery and there is no attempt to get rid of spectacles, it's probably going to be completely covered by their health insurance.
And if they're saying, I want to go premium all the way, get rid of my
glasses. It could be
glasses.
Thousands of dollars out of pocket if they want to get rid of all their spectacle and dependence. And what patients will tell us is they'll say, well, what else do I use every waking moment of my life forever? They could go on a vacation for a week or two and spend that money and then the vacation is over. But we find that patients value, as we pointed out earlier, their vision. They value it pretty highly. And their independence, I think, is really what they're trying to preserve.
This is amazing. I had no idea that look at how much I didn't know. I didn't know this is how dumb I am. I thought cataract surgery is literally removing the sort of crud that's in the lens. And I don't know, I just naively assumed it would, like the good stuff would grow back. I never knew you were putting another lens in, let alone that you could actually use the new lens as a way to correct other visual defects.
That's right. And, so the technology has evolved to the point where you can actually correct those spectacle requirements. Now, many of our patients don't really care about spectacle independence. They just want to see well. And that's easy to achieve as well. But as these lenses have gotten better, our capabilities have gotten better.
If I needed cataract surgery today, knowing my diopter, the -4, -3 business with the slight astigmatism, although I still haven't figured out how that's impacting my vision.
Right.
I guess I sort of have it, but we'll come back to that. If you were going to swap out my lens, would you be able to correct the deficit of my magnitude?
We could, yes. Yeah. Now, the problem with a lot of these eyes is they are attached quite firmly to people. And sometimes the patient's set of expectations can be unrealistic in terms of what we can deliver. And so we have to really carefully educate them on, well, what can these lenses actually do? Am I going to see like a perfect hunter at dusk while still being able to read up close? And maybe the answer is yes. Maybe the answer is no.
And can you tune it? Like, for example, if I said, Stephen, look, I don't care if I have to keep wearing contacts.
Right.
I would love to not have to wear reading glasses.
Right.
Because if I'm going to be honest with you, the reading glasses are a way bigger pain in my butt than contacts. Because I just put my contacts in the morning and take them out at night. Right. It really doesn't faze me.
Yeah,
the reading glasses annoy the hell out of me because I never remember to bring them to restaurants ever. So I'm shining a phone light at my menu and putting it out here, or I'll be reading the book to my kid at night and I'm like, oh, hang on, buddy, I got to go get my glasses. Like, that's actually more of an imposition on my life.
Yeah, it's not an unusual request. where we can intentionally set your vision for near or leave it for near. You can certainly do that. It's just an optical calculation to set the point of focus where you want it to be. You asked earlier about, well, what happens if I come into the clinic? What gets measured?
Yeah.
Well, one of the first things that we have to do is make sure that the surface of the cornea is tuned up from a dry eye standpoint, because those dry eye patients, the surface of their corneas, it's not optically pristine. It's a little distorted.
Do contact lenses make that better or worse?
It makes it a lot worse, and it can throw off our measurements, which can throw off our calculations, because it's kind of pretty simple Newtonian physics, right? If you know the length of the eyeball and you know the curvature of the front of the eye, and you know the index of refraction of the stuff that's inside the eyeball, how bendy the material is, light bendy the material is, you can correct for, as long as you know where the implant lens is going to reside, you can correct for placing that image on the retina.
So the more perfect the shape of the cornea,
right,
the better that calculation
That's right.
is.
And that is probably the weak link in the measurement, in the set of measurements that we take, because we can measure the length of the eye. We can measure the length of the eye from front to back very accurately with lasers. So we can it's almost like a sonar, but with light.
With light.
We can bounce a beam off of the back of the retina, and we know exactly how long the eyeball is. And we know roughly where the implant lens is going to rest when we put it in. And if we know some other dimensions of the eye and use the front curvature as one of our pieces of data, we can predict what power implant lens to put in.
Wow. Okay. So is there anything left on the IOL front, or is there another huge step function of technology that's going to be coming there? Because it already sounds pretty remarkable.
Well, in the mid 2000s, I started getting involved in product design for a type of implant lens that could actually zoom focus front to back, not a bifocal or a trifocal where you had different zones of focus, but a lens that could actually move or change its shape. And I developed an implant that we put in humans in multiple clinical trials outside the United States. And we found that we could zoom focus kind of like the human lens would. But the multifocals, which are the lenses we've been talking about, like bifocals, trifocal implants, surpassed the capability of what we could achieve with the lenses that I designed. And until someone comes out with a focusing implant lens that can zoom focus with the same degree of power as the bifocal and trifocal implants, it's not going to be successful. But if we had a lens that could change its shape or change its position and zoom focus seamlessly from near to far, that would be a game changer.
And I assume that you don't take like the lens from a young person who's passed away and ever try to implant that into.
No,
it doesn't work the way a cornea does.
Yeah, that's right. That's right. In fact, if you violate that capsule of the lens immediately becomes cloudy. So here's an example. Let's say that you talked about trauma. So a typical scenario is somebody is working with a weed eater or whatever, a weed whacker. Yeah. And a shard of rock or glass or something goes through the cornea and embeds itself in the lens. And it might even be an optically unimportant part of the lens. Maybe it's off to the side. But once that capsule has been pierced, inevitably lens protein starts leaking out, inflammatory cells become...
you violated the privileged site.
It's no longer privileged, and within days, you start to see a cataract.
And they need a new lens.
They need a new lens, for sure.
Do they need a new cornea, by the way?
Well, they sometimes do. But oddly enough, sometimes an object will pass through the cornea, and because it's traveling at such a high velocity, it's usually sterile, and it'll go through the cornea and embed itself in the lens or the iris or wherever. And some of these objects can be left alone. But if the cornea has been damaged sufficiently that it's no longer able to transmit a clear image, then it has to be replaced.
Wow. So let's talk a little bit about corneal pathology. So everyone's probably heard about corneal abrasions. It's a very important reason. I remember, it's one of the few things I remember, right? In surgery, you always tape the patient's eyes shut.
Right.
Because, you don't want an eyelid flipping open in the middle of surgery and nobody's paying attention and a drape is running over the eye.
That's
and
right.
Scraping the cornea. Is that the biggest insult that we think about for the cornea?
I mean, that's probably one of the more common ones. If you think about that eye that's being left open in surgery while a patient is asleep and not blinking, that's sort of the extreme version of dry eye, where the cornea has completely dried out. And even if you didn't abrade the cornea, those epithelial cells would be so damaged by exposure, just by not being continuously bathed in tears, that they would be severely damaged. So dry eye is intimately related to corneal abrasion because you lack the lubrication that normally takes place to prevent that type of thing.
And how much of an issue is that in our
dry
society?
Eye?
Yeah.
Oh, it's enormous. It's if you think about the things that cause dry eye,
there's obviously lots of medications that do it through anticholinergic side effects.
Absolutely. But think about all the antihistamines. Hormonal influences are profound in terms of dry eye. Anything that causes dry mouth can also cause dry eye. In that sense, autoimmune conditions can cause dry eye. So Sjogren's, rheumatoid arthritis, all of the connective tissue diseases have a dry eye component to them. Perturbations of thyroid metabolism cause dry eye. But a lot of women suffer from dry eye because I think it's mostly the influence of, honestly, a lack of testosterone that is probably most intimately linked to dry eye. But we see women on hormone replacement therapy that have miserable dry eye.
So you think the addition of estrogen and progesterone post-menopause could be an issue, or do you think it's still just the lack of testosterone? I
think it's the lack of testosterone.
Why do you think that?
I think it has to do with the health of the epithelial cells on the conjunctiva. But there may be also influences on the secretion of tears from the lacrimal gland as well. But dry eye is, I don't want to say it's universal in patients who are over a certain age, but it's extremely common.
So what type of eye drops should we be using? How do we apply them?
Well, it really depends on the type of dry eye that you have, believe it or not, because there are, we think of tears as just salt water, but that's really not what it is. It's really an emulsion of lipids and mucin and all sorts of immune modulators and antibodies and all sorts of things in this soup. Some of it is just what we refer to as the aqueous component of tears, really just the salt water. But the sebaceous glands that are in the eyelids, we call them meibomian glands at the little where the lashes come out of the skin. Though the secretions of those meibomian glands can become dysfunctional. And that means that the tears have a hard time gliding over the surface of the cornea. And that can lead to dry eye. So all sorts of things that cause meibomian gland dysfunction. Some of that relates to diet. And some people believe that a diet high in saturated fats is more likely to cause meibomian gland dysfunction. Certainly colder weather, the secretion, like the meibomian, the sebaceous glands in your skin respond better to sunlight, to heat. In a cold environment, those can become plugged up, and bacteria can build up along the eyelid margin, causing inflammation. And when there's inflammation, the lacrimal gland shuts down even more. So dry eye is really it's got a number of different causes.
Now, when I think about eye drops, I think about sort of the dropper that you try to get in your eye, and you
Right.
can never get it. At least I can never get it in my eye
Right.
because I end up blinking all the time. So then you try and drop it into
Into the corner, yeah.
the corner, and then let it sit. But then I've also seen like the mist, right?
Yeah.
So tell me about the different ways that one even applies.
Yeah, I think those are really the main ones. I mean, eye drops work pretty well for most people, but there are some mist sprays that, believe it or not, you can spray some of these. There's one hypochlorous acid compound that you spray on the lids, and it sort of migrates into the eye and actually is very good for reducing the bacterial counts at the lid margin, which is part of that inflammation cycle that is so critical in dry eye. But most artificial tears come in the form of an eye drop.
And that's okay. So
that's fine. Yeah.
And it's okay if you can't manage to keep your eye open, or should you force it and hold your eye open?
I mean, it's you got to, at some point you got to get it in the eyeball.
Yeah.
But that's one of just a whole bunch of strategies that we use for treating dry eye. We add artificial tears, but we think that there's a very significant benefit from supplementing with omega-3 fatty acids, especially high doses of omega-3 fatty acids and omega-6, certain types of omega-6.
Yeah, which omega-6 is it again?
Well, it's what you'd find in black currant seed oil or borage oil or evening primrose oil. That's the GLA, gamma-linolenic acid. So that is very helpful in dry eye. And interestingly, there was a very large randomized clinical trial looking at omega-3 supplementation in pretty high doses.
Do you remember how high?
3 grams.
Wow.
Of actual
of EPA and DHA.
Correct.
Yep.
Yes. And the placebo arm was olive oil, which is presumed not to have a benefit in dry eye. And it showed no superiority of omega-3 compared to olive oil. However, there's been a lot of criticism of this study. It's called the DREAM study. It was put on by the National Eye Institute. It turns out that if you bring people into the eye doctor 4 times a year, everybody gets better. Their compliance with artificial tears gets better.
And were they using artificial tears?
They were able to use whatever they would normally use to treat their dry eye. So I guess like in the same way that if you go to the dentist 4 times a year, all of a sudden you're flossing before you go to the dentist.
Yeah.
Both arms of the study got better. But it is our very strong clinical impression that omega-3s in high doses help with dry eye, primarily from I think an anti-inflammatory standpoint.
Let's go back to light for a minute.
Yeah.
So I've got some friends who are so fanatical about the importance of light that they never wear sunglasses. Now, I'm kind of, there's a part of me that thinks light is, wow, it's got to be really important. I think about, all the time I get outside in the light, it's great,
Right.
It's great. But I also like wearing sunglasses because there's a part of me that's sort of afraid that too much UV light is damaging. So what's the balance of sunglasses versus not? And I want to talk about polarized glasses. Do they matter and all that kind of stuff?
Yeah, I mean, clearly there's a dose related phenomenon here. Too much light is bad, too little light is bad. What's the right amount? I tend to recommend sunglasses for our patients. Let's start with just the most obvious one. The most common site of skin cancer, the lower lid, lots of basal cell, squamous cell carcinomas. Sunglasses certainly reduce the incidence of that. Then we look at the photo aging of the lens itself. I think it's not a bad thing to delay the onset of cataract. And then the retina, macular degeneration. I think there's pretty clear evidence that UV exposure, particularly of the magnitude that you can get outside, is associated with an elevated risk of age-related macular degeneration.
Now, do we see this in hunter-gatherers who have otherwise amazing habits and therefore tend to be relatively privileged from optical pathology?
So the confounding variable there is that Northern European ancestry is a risk factor for macular degeneration, probably because of the lack of pigment, because that pigment is protecting that very vulnerable vascularized component of the back of the eye.
Oh, wait. So the darker your eye, the more protected you are?
Absolutely. In the same way that your skin is more protected with more melanin. So light-eyed patients have more light getting in from the front of the eye. And
so their iris literally blocks less light hitting the lens.
Yes. And the retina has less pigment behind it. And so the vascular supply to the retina is more exposed to UV light. And that's the way it's evolved because they've been in environments that don't have as much light available. But if you live near the equator or your ancestry is from that area, then you're going to have more pigment and from an evolutionary standpoint. But I understand the fanaticism about wanting to have lots of blue light or bright light, but I think that it probably is fanaticism. I don't think that, at least if your goal is to reproduce, teach your children until they're 15 and then die, then get all the light you want. But if your goal is longevity or the postponement of senescence, certainly ocular senescence, I think it makes sense to protect your eyes from UV light.
So for example, so you came over here today where it's middle of the day in Austin. It's a typical Austin, beautiful sunny day. You're driving with sunglasses?
Oh, for sure. Over? Absolutely. 100%.
Okay. So you're in sunglasses when you're outside.
I am.
After what time in the morning?
If I'm outside and my vision is better with sunglasses, or, it's not worse with sunglasses, then I'm going to wear sunglasses. I don't wear them at night, and I don't wear them, if it's very early in the morning. But if conditions allow, I'm going to wear them.
We talk about with sunscreen,
right?
The importance of, you're still susceptible to sunburn in the clouds, right? If you're at the beach all day and it's kind of an overcast day, right, you can still, do you recommend people still wear sunglasses even if it's not a clear blue day?
For sure. And sometimes, this kind of came up during the recent eclipse because, people were saying, okay, I'll look at the eclipse. This one was a few years ago. I'll just use sunglasses. Well, that's actually much, 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 much worse because you're increasing the aperture of your pupil because everything is dim, but you're letting through all this very damaging light.
Because no amount of sunglasses could block a straight shot looking at the sun.
Correct. So I think even on a cloudy day, I do recommend that people wear sunglasses. Yeah.
Okay, what are polarized glasses doing?
As polarized lenses are essentially, it's a lens that has a bunch of lines drawn in it, all in the same direction, so that some of the light is blocked, but in one meridian, all the light effectively is let through, but perpendicular to that, none of the light gets through. And polarized lenses have some pluses and minuses. One of the big minuses I found is that a lot of the displays in your cars now, you get this really messed up cross-polarized effect where the light coming off of the screen is polarized. And if you look at it through polarized glasses, if you tilt your head, it gets brighter and darker. You can not see
it at some time.
You cannot see it.
Yeah.
And by the same token, many of the windows or I don't know if it's the windshield or the side windows, but I've noticed wearing polarized lenses, which I only wear for fly fishing now, that I would get these very weird effects by tilting my head because of the cross-polarized effect. Essentially, you have two different polarized filters and it's letting through variable amounts of light, depending upon the orientation of your head and your eye and the spectacles.
I have found myself more comfortable in non-polarized lenses unless I'm on water.
Yeah, I think, and the issue there is that the light bouncing off the water or theoretically a highway, it's all pretty much, a lot of it is polarized in one direction. That's the rationale behind polarized lenses. And for seeing a fish, if you're a fly fisherman, for sure, that's helpful.
I fly fished for the first time last month.
Yeah.
And I could see getting into that. That is an art.
For sure, it is. But in terms of polarization, there's no evidence that I've seen that polarization versus non-polarization in sunglasses helps. It's really the UV filter that is helpful for what we're doing in terms of protection of eye health. You could wear clear spectacles as long as they had UV protection and still achieve the benefit of sunglasses.
Yeah, that's an important point, right?
Yeah. It's not the tint.
It's not the tint.
It's the ultraviolet protection.
And it's the same as true in a car, right? I mean, the glass of the car is, assuming you don't have tinted windows, is still getting rid of most of the UV light.
Most of the UV, but not all. So you will see, and dermatologists tell us this, that in truck drivers who are in North America, they see more UV damage to the left side of their face than the right side of their face by far. And in the UK, it's exactly the opposite. So, even car and truck windows let some UV light in.
Okay, so let's now go back to the standard situation of nearsightedness. So, person comes in, they're nearsighted.
Right.
Decision one is, I'm going to correct this with glasses versus contacts. We'll start to talk about corrective surgery in a moment.
Yeah.
Do you nudge people one way or the other? I mean, I wore glasses for the first 4 years that I needed corrective lenses. So that meant basically college. I'm trying to think in med school. I think by med school, I was wearing contacts. By residency, I went back to glasses.
Right.
Because the call, you just couldn't be predictable about when you were going to put them in. So I did all of residency in glasses. And then since that time, I've been 100% contacts.
Yeah, it's funny because we'll see residents or fellows or whatever, and they come in and on their one day off and they're seeing one of our optometrists and, well, when did you last have your contacts out? And they're like, I think it was June 30th, right before my internship started 4 months ago,
Oh God.
That sort of thing. It was, and so as you know, residents are notoriously bad about their own health hygiene and because you're so busy. But and to answer your question more directly, I don't really see patients for regular eye exams myself, but so the people who see me are seeking surgery already. But in terms of, hey, I'm at a cocktail party and someone says, should I wear glasses or contact lenses or spectacles? Like, well, the safest thing you can do is wear spectacles for sure.
Wait, do you use glasses and spectacles interchangeably? That term?
Yes. When I say spectacles, I'm
That's what I thought. So yeah,
referring to glasses to distinguish them from stuff you drink water out of. So yeah, spectacles is the term of art for glasses. Yeah. Yeah. So if you, you were thinking of some sort of exotic type of.
Yes, I was like, oh,
nose-mounted
glasses,
spectacle.
But then there's a spectacle.
It's like
right.
down at ye old spectacle shoppy, something like that.
Anytime my wife talks about pushing the gas pedal, I'm like, throttle.
It's a throttle.
It's throttle application.
Yeah. We need some gas. No, we need petrol. Okay. Right.
It's gasoline
or
petrol. It's not gas. Gas refers to natural gas. When you push that thing, it's throttle application. Yes. Okay. No.
Yeah. We're hard to live with, aren't we?
Yes.
Okay. So spectacles and glasses are synonymous. Okay. That's the safest thing you can do. It's they're going to work every time, and there's essentially no risk associated with them. There's a big debate about what the next safest thing is. Is it contact lens wear for 10 years where you might be susceptible to infection, or is it laser vision correction?
Mm-hmm.
But I tend to say if you're doing fine with spectacles or contact lenses, do that.
I was kind of hoping you were going to tell me get laser eye surgery, because there's a part of me that just wants to do it for the sake of doing it and getting rid of contacts once and for all. But you were very much in the camp of, you asked me a bunch of questions, and at the end, your conclusion was, these don't seem to be an inconvenience for you. You've never once had an eye infection. You tolerate them really well.
Right.
They don't seem to bug you.
Right. And you like your near vision.
Yeah.
Yeah. And so if you were to correct your distance vision with laser vision correction and set both of your eyes for distance, you would lose that near vision. So,
until maybe I get my cataracts fixed.
That's right.
Then we can tweak it.
That's a whole other story. Right.
So let's talk about the advent of laser eye surgery.
Right.
So I think everybody listening to this has heard of LASIK.
Yes.
Most people probably haven't heard of PRK.
Right.
Which we'll talk about.
Mm-hmm.
When did PRK came along first? I assume?
Yeah, a little bit earlier. Yes.
And that was when, in the 90s?
Right. So the approvals for PRK and LASIK were in the mid 90s, 1995, 1996. The first procedures were actually done the first procedure was PRK, and it was done in New Orleans. And I happened to be in training there in New Orleans. And this was performed by a physician called Marguerite McDonald. And she did the very first treatment on a human eye. The way this came about was that excimer lasers, which are the kind of lasers we use in LASIK and in PRK, which stands for photorefractive keratectomy, excimer lasers are and were used to etch microchips. And an engineer at IBM realized that you could change the curvature, or you could make cuts in human tissue. And because of the nature of this ultraviolet laser, there was essentially no bystander trauma to the adjacent tissue. So the tissue could be etched or cut. And because it generated no heat, there was no immune response generated typically, so that these incisions or whatever they would heal without scarring. And I can remember vividly looking at the very first patients that were in an FDA clinical trial that had PRK, and I was astonished that you could look at them under a microscope and you could not detect that surgery had been done. That was really a revelation for me, where I just saw these eyes that looked like normal eyes, and the only difference was the patients could see. So the first eyes were treated in '89, and then that led to FDA approval in '95.
And the treatment in '89 was part of clinical trials, I'm assuming.
For sure. It was part of a clinical trial.
So let's explain what PRK does before LASIK.
Yeah, so the way it works is that you have the cornea, again, like the glass on a watch, the thing a contact lens would sit on. And let's say that the person is nearsighted. The cornea in that person is a little bit too steep to focus the light perfectly on their retina. Another way of looking at it is that
the cornea is about 2 millimeters thick?
No,
the cornea
it's about
is
half a millimeter thick.
Okay.
It's about 500 microns, maybe a little more. So either the cornea is a little too steep or the eyeball is a little too long, probably a little of both. We can't change the length of the eye.
By the way, the length of the eye is the one that we talked about being somewhat malleable during development.
That's right.
And is the corneal shape hereditary? Is that the hereditary component of vision?
The corneal shape doesn't seem to change that much throughout life. It's the length of the eye that changes, unless there's a pathological condition that changes the cornea. So since we can't change the length of the eye, what we can change is the curvature of the front of the eye. And if you think about it, you don't have to change the curvature that much. Think about how thin a contact lens is.
How thin is I mean, I know I can feel it, but I don't know what that is. That also about half a mil?
No, it's less. I honestly don't know. I don't work in that world, but it's pretty thin. I mean, it's like a little piece of cellophane if you think about like an AccuView disposable.
Yeah, it probably just feels thicker because of all the goo on it.
Yeah. I'm sure someone will correct me and say, you should know how thick a contact lens is. I don't, but it's thin, right? It's pretty thin.
Yeah.
So it's just that little curvature that needs to change in order to focus the light on the retina.
And just to use an extreme example, so you take somebody who has a very minimal degree of nearsightedness. So let's say their diopter is -1.
Right.
And then you contrast the lens that they would wear to the lens that's someone who's near blind at like a -10.
Right.
Is the -1 creating more of a bend or less of a bend? Meaning, is it a bigger curve or a smaller curve?
So the person who's -1, their cornea is less potent in bending light than the -10 person is. That -10 means their eye is 10 units too strong. And we need to reduce the power of the eye. So how would you fix that with a laser? Well,
first of all, how do you fix that with the contact? So their lens has to look...
The curvature of their lens
contact
has to be effectively flatter than their eyeball. So you need a larger radius of curvature or a flatter eye.
I got it. Okay. So you would actually build up the outside of the lens.
Exactly right.
Okay.
So it's even easier to explain with laser vision correction. So let's take a crude analogy, which is that the cornea is made out of wood and I have some sandpaper. Well, I can sand down the center of the wooden cornea and make it flatter.
Off.
And I'm removing some sawdust goes away. And now that is flatter. And so it's less powerful in bending the light, and I can focus that on the retina. So in your -1 example, we would remove about 20 microns of tissue. That's not a lot. You figure a human hair is about 50 microns. So, like less than half of one human hair's thickness.
And PRK does that
with
directly
with an excimer laser on the very front part of the cornea. So the way we do it is that the very front coating of the cornea is called the epithelium. It's a very thin layer, kind of like.
How thick is the epithelium there?
So it's about 50 microns, something like that, 50, 55 microns. So it's got a basement membrane. But it's about, call it 50 microns. So we remove that layer of cells with the way I do it is with a solution of some eye drops of alcohol, and it just sloughs right off and it grows back. Just
like isopropyl alcohol?
Yeah, you could use that or ethanol. And
you've anesthetized the eye before doing that, obviously.
That's a practice builder. Yeah. When you thank you for that tip.
How do we get the repeat business?
So,
I don't know why no
Why don't
one's
we numb the eye
back?
first? That'd be really good. Yeah.
Okay.
So you anesthetize the eye, and then you put some alcohol solution on the front of the cornea. You remove that epithelial layer, which is going to grow back in the same configuration. And then you use a very carefully calibrated laser to change the shape of the cornea.
Again, dumb question. The laser's coming at what angle?
It's essentially effectively perpendicular to the cornea. So the patient's laying down flat. They're on their back.
And you put something in to wire their eyes
We're
open.
holding their lid apart
for them.
Are
they
sedated? I honestly give people Valium because it's just sort of an intimidating minute. It only takes a minute.
Here's what my fear would be in doing it is like my desire to blink would be so overwhelming. I'd break the little eye barrier. Of course I wouldn't, but I'd end up moving my head and you'd zap the wrong part of my eye and I'd be blind.
That's everyone's fear. It turns out Valium is undefeated. It's just a question of how much, but it's a very good drug. But to address what you brought up several things there. First is a lot of patients fear that they'll do something to goof up the surgery.
Yeah.
And there are a number of reasons why that really can't happen, but let's go through the procedure from the beginning. Long before this patient ever laid down on this gurney to have this laser treatment done, their eye was digitally mapped using what we refer to as a wavefront sensing device. So think about this. We send in a very narrow beam of light with a laser, and we look at how it bounces back from the cornea. It bounces back in a distorted fashion. So we send an ideal ray of light in, or multiple rays of light in, and they bounce back in a distorted fashion. The amount of that distortion allows us to map the...
So you do a topo map.
It's much more than a topographical map. It's the entire optical pathway of the eye from the retina to the back, all the way to the back and front. So we look at the entire distortion pathway. And there's more than one way to do this, by the way. There is a topography-based way to do this as well, which is very effective. But the one I'm describing to you is sort of the easiest one to think of. We send in a known uniform beam of light and look at how it bounces back from the back of the eye. That tells us what are the distortions present in this eye. How much nearsightedness, how much farsightedness, but also all of these physics terms of...
We didn't do this in me, right? You only do this in someone who's going to be a candidate?
We may have done it in you just for grins, but we diagnostically, this is part of our workup for laser vision correction. And we look at how this particular eyeball, Peter Attia's right eye, distorts light as it goes through the optical pathway. This technology was developed for telescopes that have to contend with atmospheric distortion. So the way this works is that telescopes, and I'm talking about like Keck, and the best ones in the world, they send up a diagnostic laser into the atmosphere, and the distortion that that laser is encountering is adjusted for in real time with a deformable mirror, a very thin mirror. And that allows them to essentially correct for the distortions of the atmosphere in real time. And those are constantly changing. We have the benefit of not having to deal with real-time evolving distortion, but we can take a snapshot of what are the distortions of Peter's right eye. And then we can build them into the laser vision correction that we do on Peter's right eye. Part of doing that means that we have to be able to track your eye. So we have to lock onto and register your eye with the equipment, and any movement that you make, part of your fear was, I'm going to mess it up. Well, the laser can track far more rapidly than you can move your eye.
So while you're doing this, patients' eyes can be moving.
They can.
And it doesn't matter because the laser's moving.
I mean, it's sort of annoying when they, so we coach them, hey, look at the flashing light.
Yep.
But that's really just to keep them in the ballpark of where the tracker can lock onto them.
I like knowing I'm not the only one that has this ridiculous fear.
It's not a ridiculous.
Blinding himself.
First of all, it's not a ridiculous fear. Secondly, it's universal. When I say to patients, "Hey, I'm not going to let you do anything to mess this up," they're like, "Thank you, thank you for saying that. That was the thing I was worried about." Because you don't want someone to laser your eye and you looked off to the side. Oh. Disaster.
Not only are you blind, we also gave you a brain tumor.
That's right. So the laser will not fire unless you are within its range of tracking, and it will move faster than you can move.
So PRK is, I like your analogy, basically changing the shape of this via the mechanism of it's not sanding it off, but it's
vaporizing the tissue.
It's vaporizing the tissue.
And it's a laser that's sort of scanning around the cornea, where it does a little treatment here. And then we know thermally that we don't want to do another shot right next to that one. So we move over here and we want to let the tissue cool down for a few milliseconds. And then we go over here. So the laser dances around.
And how many minutes approximately does it take? Does it take longer the worse the prescription is?
Yeah, for sure.
You have more to shave.
So like -2, it might be 15 seconds.
That's it?
Yeah. Maybe it's, maybe.
So -10 would be how long?
Like a minute or so. It depends on the laser. It depends on the overall treatment size, how much astigmatism, and how many.
Oh, you're fixing the astigmatism as well.
And all the little distortions, how much coma, trefoil, all these are physics terms that I didn't really think I would become fluent in, but all these little optical distortions that optical physicists are very familiar with, we measure and do our very best to eliminate with laser vision correction.
So the whole procedure is what, half an hour by the time you get the eye, put this thing in the eye, put this thing in the eye, give them their Valium.
For PRK?
Yes.
2 or 3 minutes plus the Valium time. So
take your Valium an hour before.
Or maybe it's like half an hour. We have them chew it up and then it works pretty quickly.
Okay. So talk about the recovery from PRK, because one of the things I remember you saying when I was sort of humming and hawing about this was the biggest drawback of PRK is the recovery takes longer. But you otherwise, I think, really talked about PRK as the gold standard.
I think it's the only reason I might have said gold standard was that it came first. It was the first procedure. And if you look at PRK and LASIK, which we'll get to in a bit, if you look at those procedures, say 30 days later, they're indistinguishable in terms of results. But the LASIK patients get there way quicker. So PRK, now I've removed your epithelium. So now you have this, let's say it's a 7 or 8 millimeter diameter area of your central cornea that has no epithelium.
It's like grow back.
That's like having a big corneal abrasion, essentially. Luckily, we have drops that can reduce the feeling of the foreign body sensation dramatically. So we put those drops on the cornea, put a contact lens over the eye like a Band-Aid. It's really like just a regular soft contact lens. And then the epithelium begins to heal from the outside in. And that takes
30 days?
No, that takes about 4 days.
Okay.
But here's the thing. It's like, if you were to have a cut on your arm, it would heal over, but you'd still be able to detect where that cut was because those cells have not fully remodeled themselves. So the cut heals over, or the defect in the epithelium heals over in about 4 days, maybe less.
And then you take the contact lens off after
You can
4
take
days?
the contact lens off then, but the vision is still not perfect yet because those cells have to reorient themselves like, a bunch of orderly bricks in a brick wall. And when the cells first cover that defect, it's a very thin, sort of disorganized layer of cells that have accomplished their mission of sealing the defect and preventing you from being susceptible to infection, which is their job, to quickly cover the defect. But then the body can turn its attention to reorganizing those cells in a.
So you do one eye at a time, obviously.
Not with PRK or LASIK, no, because the level of vision, typically we do both eyes on the same day, because the level of vision is probably about 20/30 or 20/40 within a day or two. So when I say the visual recovery takes a while, you get pretty good pretty quickly, but that last little bit takes several days. So you probably could drive a couple, maybe 2-3 days later, but you wouldn't have 20/20 vision at that point.
So LASIK, the only thing I know about that is there's a flap involved.
That's right.
So presumably you're not shaving off the epithelium, you're cutting a flap, and how much of that tissue you take off determines the shape of the new cornea when the flap comes back?
Right. So the laser that does the vision correction, all the little distortions, the nearsightedness, the astigmatism, that's all the same laser. So that part of the procedure is identical. But instead of doing that on the surface of the eye, now we're using a step before that where we create a flap in the cornea using a different type of laser. So we use a femtosecond laser to create about let's say 100 micron flap. So we are now under the epithelium.
So you've taken 20% of the cornea up.
That's right. About 20% of the cornea up. And now think of it as, in our analogy where we were sanding a wooden eye before, now think of the cornea as a book. And in PRK, I'm removing the first 10 pages of the book.
You're opening
now
the
I open
cover,
it to page
taking the
100 and I'm taking out 100 through 110. And then I close the book. The beauty of LASIK is that because that tissue removal is sequestered under that flap, the body doesn't perceive that anything has been done. So it's very typical for patients who have LASIK to be 20/20 the next morning. And so that's the appeal of that procedure.
And that's why LASIK was developed post PRK, presumably as a way to get around the healing process of PRK?
Yeah, that was sort of a technological race, and the way it developed was interesting, and some of it was in pursuit of more rapid visual recovery.
So what percentage of corrective eye surgery in the United States today is PRK versus LASIK? I assume the lion's share is LASIK.
Yeah, I think it changes, but it's probably about 80 to 85% LASIK. And not to confuse things, there's another procedure called SMILE, which is a very small but perhaps growing segment of the market. And we can talk about that in a sec. But the lion's share of it is LASIK. And there is a significant chunk PRK. And
Are there more risks in LASIK than PRK?
Well, the risks are different because the risks of infection with LASIK are lower because you don't have this
open. You don't take the epithelium away. That's
right. But you introduce another step in the procedure where you now have a flap, and that flap can, if it's not performed correctly, that can lead to problems. I think there's a little bit more dry eye issue with LASIK compared to PRK as well, because when you create that flap, the way tearing works is that a signal from the front of the eye goes to the lacrimal gland, which then secretes tears. If you create a flap, you temporarily sever some of the nerves that are sending the signal. And eventually, over time, those nerves typically regrow back and you reestablish that feedback mechanism. But I think you get more dry eye with LASIK than with PRK, and for longer. That is a controversial statement. There are people who have data to show that they're equal, but I think they both result in temporary dry eye in most patients. Some patients have dry eye for really long periods of time after both procedures, but the majority of patients are kind of back to their baseline in about probably 60 to 90 days.
What about night vision or low light vision?
So that's fascinating. There, in the early days of LASIK and PRK, the weakest part of vision was night vision. And that was because the shape of the treatment that we did and the diameter that we treated was limited. So we couldn't really treat the peripheral part of the cornea that comes into play when your pupil gets big. So if you are treating a central part of the cornea that is smaller than a big pupil at night, you're going to see halos from that untreated peripheral part of the cornea. Over the last, from the 90s to now, the treatment beam patterns have changed to address that issue and to treat that peripheral cornea differently. So now night vision complaints we find to be pretty unusual with laser vision correction.
Is there a difference in the cost of these procedures?
I mean, for us, no, but I'm sure there are some surgeons who charge more for one than the other. The added step of LASIK adds some cost, but PRK has more post-operative care, frankly, because it requires more visits to see these folks. But we price them the same.
What are the and how much does it cost? By the way, I mean it's probably come down a lot in 20 years, right?
You know, I don't think that it has. I think it's been pretty stable. I think that I think it's probably about a couple $1,000s per eye is about the average in North America that you'll find.
What are the exclusion criteria? Like who is not a candidate for either one?
There are certainly contraindications, some of them relative, but some of them are absolute. I'll give you an absolute one. There are conditions of the cornea where the cornea is biomechanically unstable, where the cornea is actually has a tendency to bow forward in a pathological state. And that means that the cornea is not, it's a moving target essentially. So further biomechanically weakening the cornea makes no sense. And doing either procedure would do that. There are patients who have irregularities in their astigmatism that cannot be measured or corrected with any laser vision correction. There are patients that have certain autoimmune diseases that maybe render them as poor candidates for laser vision.
Based on the risk of healing, or?
Based on the risk of healing, or perhaps just the overall health of the eye. And that sort of extends to people who have other eye diseases like cataract or maybe glaucoma or retinal pathology. You are typically operating on healthy eyes when you're doing laser vision correction. So if there's some other issue involved, you might not be a candidate.
And is there anything that, I guess given the differences you've explained, why are 15% of people still opting for PRK?
Well, there are certain patients where that's a far better option. So we talked about how you're removing pages from a book.
Yep.
Well, what if you have a really deep treatment that you need to do and the book is sort of thin to start out with? Maybe it's better to begin on page 1 than to begin on page 100. So sometimes
the stronger the diopter and the thinner the cornea, that might move you more towards PRK.
Sometimes the thickness of the cornea will dictate it. Sometimes it might be related to someone with pre-existing dry eye. And we're thinking Well, we have data that these two procedures are about the same in terms of dry eye, but our clinical impression is that LASIK makes them a little drier. So maybe let's do PRK on this particular individual. There used to be some restrictions in branches of the military.
Right. I remember that you couldn't have a flap in your eye if you were a pilot.
That all went away.
Okay.
So pretty much all the aviators and pilots can now have LASIK or PRK. In fact, the military is one of the largest providers of laser vision correction now in the United States. But there are a couple of holdout special forces branches where they don't want you to be maybe an Army Ranger. And that has to do with getting poked in the eye. And the possibility that a flap could be damaged. And some of this is sort of vestigial lore, and it's hard to change the military's rules.
But they'll just say PRK or nothing.
Yeah, but I'd say that the overwhelming majority of the branches of service allow either treatment. And certainly all the commercial airliners, they allow PRK or LASIK, but with the caveat that you have to get to the point where you can pass the flight physical. So, and the same thing's true of people who want to be pilots or aviators. If they need to have 20/20 uncorrected vision to be a pilot, they have to have 20/20 vision after laser vision correction.
Is it pretty much a given that you can at least get someone to 20/20 after laser corrective vision?
I mean, the way the lasers are built today, it's typically the case that you can get them to 20/20 or better than 20/20, as we were describing before.
And if you take them to 20/15 and they have presbyopia to begin with, does it get any worse, or is it just that now they're noticing it all the time because they never get a break from it? They never get to take their glasses off, their spectacles, so to speak.
Well, if you nail it perfectly so that their prescription is 0.00, I think their distance vision will be phenomenal, and their near vision will be whatever it is based upon their age. So if they're 50 years old, they're probably going to need some near correction, some spectacles for reading. If they're 41, 2, 3, 4, maybe even 45, they may not need glasses for close up.
And then you mentioned this SMILE procedure. I haven't heard of that. What is that?
Yeah, it's an interesting procedure. It's using a single laser, a femtosecond laser. And this is, I want to go back to the book analogy where we opened the book to page 100. Well, imagine if you could somehow create a little tunnel down to page 100 and snatch out pages 100 through 110 while keeping the incision really tiny and perform it through a very small keyhole procedure. That procedure has gained some traction outside the US and in the US. It seems to be an effective procedure. What
problem is it solving, given how effective LASIK is?
I would say the problem it was designed to solve was dry eye.
Okay.
But I think the problem it really solved, especially outside the United States, was needing two lasers versus one. So maintaining and...
Although you could do one with PRK.
You could do one with PRK, but then you have the prolonged, recovery time. So the idea was, could you get LASIK-like velocity of return of vision
with a single laser?
With a single laser.
And maybe along the way, reduce dry eye.
Yes. There are pros and cons to SMILE. The technology is evolving. I have not seen any data that shows that SMILE is in any way better than LASIK or even equal to LASIK, frankly. But it seems to be a very good procedure.
Are you doing it
I
as
am
well?
not performing SMILE, and doesn't mean that I won't in the future. And there are a number of competing second and third generation versions of SMILE that will come on board. And if one of them ever rises to the point where I think it's better than what we're doing, we'll offer that.
We didn't talk about glaucoma, yet I know every time I go to an optometrist, or even when I came and saw you, is that the one where you blow the air at my eye?
Well, that's sort of
well, that's just an intraocular
that's
pressure
a
test.
way of measuring the intraocular pressure that we don't use, but it has the advantage of not requiring the patient to be touched with anything. So you can indent the cornea with a known amount of force from an air puff, and look at how it optically deforms. The disadvantage to the air puff, and it's not really considered I don't think a gold standard of measuring pressure, is that if you blink really quickly and squeeze, then you can have a false reading with that type of air puff tonometry. And we typically don't use that.
How do you measure intraocular
We measure
pressure?
it with two ways, both of which indent the cornea, physically indent the cornea.
So that's why you anesthetize
after you anesthetize the eye with a known amount of force, and then you look at the amount of force required to cause a certain amount of indentation.
And what's the definition of glaucoma?
Well, glaucoma is probably about 100 different diseases, honestly, but they all share the final common pathway of damage to the optic nerve, the nerve in the back of the eyes, the cranial nerve that you mentioned at the beginning, that is somehow related to pressure. So a pressure-related optic neuropathy. Now, what's odd about glaucoma is that there are people who have totally normal pressures with relation to the population, but that pressure is too high for them, and they can develop damage to their optic nerve.
And the symptoms of glaucoma, are they all this? I mean, is it always some change in vision? Is that what would bring someone to attention if they weren't getting a screening test?
It's funny. You just sort of like triggered a memory of mine. I had a patient, I was in training years ago, and I was explaining to a patient that, glaucoma is totally, has no symptoms at all. You wouldn't notice it at all. And yet, if we don't find it, it could be really bad. And the patient said, well, if it has no symptoms, what do I care? What's the point? And what I should have said was that it has no symptoms until the very end.
Yeah.
So what happens is that your peripheral vision is damaged, and most people will not detect a slight reduction in their peripheral vision, particularly if it's segmental. If there's just one little area off to the side that they can't see, particularly if the other eye is covering for that area. But as glaucoma progresses, it can affect central vision, and then it becomes symptomatic.
How much of a problem is this in the United States, first of all, and then in the rest of the world?
Well, luckily, glaucoma has become much more treatable. So the pharmacological management of glaucoma has gotten way better. And there are numerous laser procedures that can treat glaucoma, and what are referred to as minimally invasive glaucoma procedures, or it stands for, MIGS, minimally invasive. Basically, the management of this has gotten way, way better.
What are what's the 80-20 of this? What 80% of them are caused by what, basically?
Yeah. So 80% of them are caused by what we refer to as garden variety chronic open angle glaucoma, which means that it's the glaucoma is not a function of the anatomy of the front of the eye being too crowded where the fluid can't get out. It's more a problem of overproduction of fluid inside the eye, and the pressure is too high inside the eye.
The vitreous fluid?
No, it's the aqueous fluid.
And what causes that? Is that endocrine? Do we not know?
We do not know. I think this has a multifactorial pathogenesis. There are certainly family history components to this where we see it run throughout families, but it's not like inheriting.
Does this run in parallel with diseases like type 2 diabetes, or is it uncoupled completely?
No, not really. It's not really coupled with diabetes. There's some relationship to hypertension, but blood pressure, but ocular hypertension, we refer to eye pressure being too high. You see it in patients who are not hypertensive at all.
Wow. The lifelong incidence is what?
I think you got me there. I honestly don't know, but it's
common or uncommon?
It's very common. Every eye surgeon sees glaucoma patients daily, multiple glaucoma patients daily.
So, presumably, like any neuropathy, if you catch it early enough, it's fully reversible. And if you catch it too late, you damage it, or is it because this is not this is a central nerve, not a peripheral nerve. So I don't.
Yeah, it's not. Yeah, I think it's you can arrest the progression, but I don't think you can undo the damage that has occurred. So once there's been optic nerve damage,
it's not like sciatica.
No, I don't think so.
Yeah.
I think once there's been damage, we expect that damage to remain. So it's not unusual for a patient to have what we refer to as a visual field defect. So a little area missing from their field of vision. And our goal becomes to prevent that
From
defect
spreading.
from getting any bigger. And you can typically do that once you identify it.
At what age does it start to become enough of a concern that we should be screening for it?
Yeah, I mean, I think everybody, when they go to the eye doctor for a yearly exam, gets screened for glaucoma. The appearance of the optic nerve is examined, as well as the pressure. And those are probably the two most important things to look for with glaucoma.
So if you're screening annually,
you're being checked for it.
You're in good shape.
Yeah, you're being checked for it. The incidence does go up with age. And so in the 50s, it's much more important to pay attention to glaucoma and beyond.
And presumably in the developing world where people aren't going to get eye care, or even in the United States, if people don't choose to get eye care or can't afford to get eye care, it's a bigger risk because they'll only present when they have symptoms.
That's right. That's exactly right. Yeah.
All right. So to summarize, again, we think about kind of the longevity of the eye is a pretty important thing, right? If you want to figure out a way to live to 100, we spend a lot of time thinking about, well, you've got to really, really delay the onset of atherosclerosis. You have to have a very aggressive strategy around the mitigation of cancer, Alzheimer's disease, and all of these things.
Right.
But it's these other things, teeth, ears, and eyes, that I don't think get enough attention, right? I mean, you don't want to get to be 100 and have no teeth, and you don't want to get to be 100 and be deaf, and you don't want to get to be 100 and be blind.
Yeah, those all sound bad.
Yeah. So, I mean, the things I'm picking up, unfortunately for many of us listening to this, we can't go back and change what we did as kids. We can certainly make a change in our kids, so we can make sure that they are outside in natural sunlight.
Right.
I don't put sunglasses on my kids. Should I be doing that?
Yeah, I mean, probably. It's trying to get a kid to wear sunglasses is tough.
We gotta come up with better toys. Like, my kids love trains, so if I could figure out a way to tell them that wearing sunglasses was train-like,
right,
this would be good.
Yeah, it's tough. I mean, you see kids who are snow skiing, for example, and they should be wearing goggles because those have built-in UV protection. So that typically works, for that type of thing. But gosh, when they're water skiing, they certainly can't wear glasses. If they're swimming, they can't wear sunglasses. There's a certain...
Although goggles these days are pretty good.
That's true.
Front, yeah.
Yeah, it's hard to get my kids to wear goggles, but there's a certain amount of just UV exposure I don't think it's possible to avoid.
So the trade-off is, when in doubt, keep them out.
Yeah. Hats are important as well. We didn't really talk about that.
Yeah.
I think that's a very good and effective way, but it's not enough because a certain amount of light bounces off and hits the bottom of your cheek and goes right into your eye. So
for those of us that are now adults, basically we've kind of cast our lot with respect to that malleable period of changing the length.
Well, we didn't really talk about like what nutritional supplements might have some effect. And it's interesting because we know that with cataract, that vitamin C deficiency is associated with an elevated risk of cataract. But it's been shown really conclusively that vitamin C supplementation to supranormal levels does not protect against cataract formation. And the things that have been looked at, I know A, C, and E, basically antioxidants have been looked at. They've had no effect on cataract formation. There is a little bit of mixed, weak evidence for lutein and zeaxanthin as possibly being protective for cataract.
Also antioxidants, right?
Yes, that's correct. And, the macular degeneration, we didn't really touch on that very much, but that's a huge problem. You may have seen in the drugstore, they sell AREDS, AREDS formula for macular degeneration. That stands for the Age-Related Eye Disease Study. That was, again, a National Eye Institute initiative. And first, they looked at CE and beta carotene with zinc and a little copper. I guess they put the copper in because they were worried about copper deficiency with zinc supplementation. And then they got concerned about beta carotene. So they did another study where they took beta carotene out and put in lutein and zeaxanthin, powerful antioxidants. And what they showed was that you could delay or reduce the conversion of mild macular degeneration to severe, but it had no effect on severe disease. And it also, interestingly, had no effect on people who didn't have macular degeneration. It didn't prevent them from going on to get it. But I think most of us believe that there's something there. There's some signal embedded in that noise.
Is light also a big risk for macular degeneration?
It is. It is. So again, it's this dose thing. We want enough light so you don't become nearsighted, but not so much that you're frying your retinas and giving yourselves cataracts. But I do think that some form of broad spectrum antioxidant protection makes sense.
We didn't really talk explicitly about screen use.
Yeah.
Is there, I mean, you talked about it a little bit in that study in Asia where, but I don't know if that was specific to screen use or just could have been just as much reading.
Yeah, it was not specific. Yeah, it wasn't specific to screen use.
So what do we know about phones specifically and computers?
Yeah, so, this is a super interesting, obviously, topic. And everything from people ask me about blue blocking glasses. They ask about, am I damaging my eyes? Am I going to get macular degeneration because I'm looking at a computer screen for 10 hours a day? I'll start with the easy ones. The amount of UV radiation coming off of screens is sufficiently low that there has been no evidence at all that it's going to cause macular degeneration. In the same way that you can't get a sunburn from a screen. I mean, the amount of blue light that you get from going outside is many, many, many orders of magnitude greater than what you can get from screens. But I do think that blue light can mess up your circadian rhythm. And it's, if you take someone and expose them to blue light at noon, that's great. If you expose them to that at 11 p.m. and then you try to go to sleep, that's messed up. It's almost like we're running this gigantic experiment with humans where, think about like you have a turtle. Let's say you take a species of turtle that spends 90% of its time in the water, 10% on land, and we take that and flip it. Now it's 10% in the water. And then we look at these turtles and we think there's something weird going on with these turtles. Yes, they're surviving, but we've got them in a very altered environment compared to what they were evolved to deal with. So giving people blue light from a screen that's bright at 10 p.m., 11 p.m., and then asking them to go to sleep is a problem. So, I really try to limit.
It's not clear that it's damaging their eyes.
It's not damaging their retinas or they're giving them cataracts, but I think it's messing up circadian rhythms. So,
although it is hard to disentangle that from the total amount of light that they're seeing, which is also unnatural, and what comes with it, which is the stimulation.
Right, like you're thinking.
I mean, there seems to be a difference between watching TV and checking email before bed. Maybe neither are ideal, but one seems demonstrably worse, at least for me.
Yeah, I think that's pretty universal. People feel that way, that passive watching a TV is different than I wonder where Winston Churchill is buried. You go down some wormhole and you're just seeking information that takes you on these journeys. But one thing I do have software embedded in all of my PCs that changes the color temperature.
Like Flux or something.
I love Flux. Yeah. And Flux is free, by the way, I think for end users, and it will take the blue light sequentially out of your monitor as the day goes on, as the evening goes on, to the point that it's like super amber as you get ready to go to bed. I really think that's great.
Anything else we should be thinking about? I mean, the big takeaways for me have been the importance of sunglasses, artificial tears, taking your contact lenses out as frequently as possible, right? So don't sleep in them and stuff like that. I know it's not your field, but do you have a point of view on daily versus the ones that, it just seems to me dailies, if you can afford them, make more sense than the 2-week ones that you have to watch every night?
Yeah. So, I think the most important thing is that you just get them out of the eye. We really don't like extended wear contact lenses. So whatever type of contact that is, as eye surgeons, we tend to see a selected sample of patients who are the problems, the people who have sight-threatening infections from sleeping, typically in contact lenses. So yes, I realize there are millions of people who sleep in their contacts and don't get infections, but the people who end up in my, office have had problems, and some of them quite devastating problems. So I'm not a big fan of sleeping in contact lenses in general, but if you're going to sleep in contact lenses, I'd rather they be a perfect, pristine new pair every single time and get them out as quickly as you possibly can. So yeah, I
talked about eye protection.
Yeah.
Again, I think we're a little more aware of that now than when we were kids. The other takeaway for me is not to be so afraid of cataracts. They're inevitable, and you can actually, there's a potential silver lining, which is not only the improvement of your vision, but potentially the correction of other age-related visual changes.
It is interesting that once word got out in the community that this was something that could be done, you do see people coming in asking for cataract surgery, I think a little bit sooner than they otherwise would, because they know that this added benefit is a potential possibility. In the old days when we did not have intraocular lenses, or the generation, a couple eye surgeons before me did not have intraocular lenses, you'd have to wear these, what were called cataract glasses, these super thick lenses that were very, very powerful and magnified everything and didn't really work all that well optically. So in that context, people—
Wait, you wore those post-cataract?
Post-cataract, yeah, because there were no implant lenses.
Oh, wow.
And your prescription was typically about a +10. So you know that a -10 is a very,
so
very
these
nearsighted.
people can't see without these glasses.
That's right. And so
These are like the Coke bottles.
That's
where
I don't even know
glasses
if
and
people—
spectacles meet.
Do people even know what Coke bottles are anymore? So the bottom of a Coke bottle is a really thick piece of glass, and this would magnify your eyes and make your eyeballs look enormous.
Yep.
And then you would have all sorts of optical distortions, because it's very hard to make a super powerful magnifying glass that
with a long enough focal length that you can,
without peripheral distortion.
Yeah.
And so you, in that context, would put off cataract surgery as long as humanly possible. So that's really not the case.
Is cataract surgery one and done? I mean, you said it should be, but do people ever need reoperations?
I mean, it's not unheard of where someone will have an implant lens put in that isn't functioning the way it should, and that can be replaced.
Difficult to get the old lens out since you can't use the same technique to melt it away?
Not really. You can just fold it, pull it out, or
so it doesn't
cut it in half.
It doesn't re-epithelialize, or the crispy, or the candy coating of the M&M doesn't stick to the new lens.
A little bit, but you can fray it up and take it out. You can swap out an implant lens. It's something that we don't do it. It's not like changing your shirt, but you can certainly do it. It's another operation.
One other question I had on the laser surgery I forgot to ask was, how stable does your prescription need to be? Because if I understood correctly, again, there's two things that are driving that, right? There's the length, which presumably that's the part that needs to be stable. You don't want the length to be changing.
That's right.
But the shape of the cornea, you're actually fixing. So if there's anything that's changing there, do you care?
Well, there's really three variables if you think about it. There's the cornea, the retina, the length of the eye. I shouldn't say retina, but the length of the eye, and the lens itself. Yeah. So we know that the lens is going to continue to change throughout life, but typically not until you're in your 50s, 60s, 70s, when cataract formation will start to affect the light bending power of the lens. The cornea should not be changing. That would be a sign.
You just have to make sure this length is fixed.
That's right. And typically that, unless you're someone going back to law school or you're reading 30 hours a day, that is typically finished changing in the early 20s, like around 23, 24.
So does that mean our prescriptions shouldn't be worsening much as we age?
They really should not be worsening unless you're developing some cataract formation.
Okay. Yeah, I think mine have been stable for about 15 or 20 years. So that means I'd be safe to have laser eye surgery from the standpoint of stability of prescription.
From the standpoint of stability of the prescription, that's right. And then at some point in your future, and we tell patients this, at some point you're going to start to develop some cataract formation, and hopefully the boxing won't have any effect on that. UV exposure, you won't have any effect on that. Genetics will be in your favor. And, but if you're I didn't mention radiation is another, we see people who do fluoroscopy, like health professionals who are involved in exposed to ionizing radiation. I mean, if you're the tech working, if you're the ship captain who smokes on a boat that's carrying nuclear waste and you're diabetic, you're going to get cataracts
a lot sooner.
Yeah.
Yeah. So that last thing I want to talk about was, are we ever going to have a day when, just as we look at hemoglobin A1C today, which is a pretty crude, unimpressive way to assess glycosylation.
Right.
I've ranted on this elsewhere, so I won't waste your time with my rant on why I think hemoglobin A1C is not especially helpful outside of extremes. But I don't know why. I just think the eye is the most sensitive end organ to excessive glycosylated hemoglobin. And it's also one of the few things you can look directly at.
Yeah.
So, I know when I was in your office, just for giggles, I wanted to have you do like basically an angio of my eyes, non-invasively.
Yeah.
And I thought that was really cool. I liked knowing that I had beautiful little vasculature back there.
Your capillary network was the envy of everyone in the office. Really, really good. No, but what's so
like,
cool?
what stands in, I mean, is there going to be a day when everybody's doing this every year, and when we see changes there, we say, you know what, I don't care what your hemoglobin A1C might only be 5.5, you're quote unquote normal,
right?
But that might actually reflect higher turnover of RBCs, and in reality, there's a problem.
So one of the really interesting things about the eyeball is that it's a transparent organ, as you point out. So you can just sort of look in and see what the problem is. It's not like, okay, there's belly pain, we need to do some testing.
Yeah, it's not like the spleen where you have to use more complicated tricks.
That's right. You can just look in. And because, for example, we have a layer of brain tissue readily available for us to observe, including its capillary network. So we can look and see, are these capillaries damaged, which is something you see in diabetics? Are they exudating fluid? Are they leaking fluid? And that's a very early sign of diabetic retinopathy. Could you, for example, image the lens and determine, is glucose leaching into this lens? Does it contain more glucose than you would expect a normal individual to have in their lens? Might that be a screening technique for diabetic disease? But I think probably yes. And what about the fact that diabetes manifests primarily as a microvascular disease in so many end organs, and we can actually directly visualize this microvascular disease occurring. So if it's in the eye, it's probably in the kidney, it's probably in the toes. And those are things that we can directly observe.
And again, it's not binary, right? So it's not, we make the diagnosis in a very binary fashion. When the hemoglobin A1C hits 6.5%, the person has type 2 diabetes. But at 6%, we just say they're pre-diabetic, and at 5.6%, we say they're normal. But of course, if you understand everything we're talking about here, that couldn't be further from the truth. It's not like a person's going to be perfectly pristine and then they're going to be diabetic. This is a spectrum. And I just think that this, to me, is a much more interesting way to go about gaining kind of a foothold in our understanding of a person's metabolic health, is to sort of create this as now a new standard, right? This something I'm going to create as a standard for myself, right? Which is, I want to make sure that these, nearly invisible arteries and capillaries are perfect. And when they cease to be, it's going to prompt investigation, right? Whether it be lipids, whether it be glucose, whether it be any other thing that blood pressure, right? I mean, all of the things that can damage a microvascular system, this becomes a beautiful window in which we can look at them. What is the cost of doing that test? If a person said, I just want to...
Yeah, it's super inexpensive to do, but I honestly believe that we would see perturbations in the glucose migration into the lens way sooner than we would see architectural changes in the retinal microvasculature. I think that the first...
And you measure that via pressure or shape as well?
So the technology to measure glucose in the lens doesn't exist commercially, although it's being studied. You could look at how the lens essentially reacts to light that you shine into the lens with a particular wavelength and determine how much glucose there is in that lens. And is that abnormal compared to a normal population? But looking at the retinal vasculature, we can do that with ocular coherence tomography, or optical coherence tomography, I should say. And we can image in a non-invasive way the capillary network. But again, I think that's going to happen. The changes there would happen after.
But I bet you see a lot of damage there in people who are unaware of their metabolic state, right?
You do, for sure. In people,
but it's not the canary in the coal mine. You're saying the canary in the coal mine is actually going to be the lens distortion due to the osmotic effect of glucose.
In initial diagnosis and screening, yes. But what happens very commonly is that a diabetic will come into us and say, my sugar is well controlled. My doctor told me I'm under great control. And we look at their retina and there's no way they're under great control. They have fluid exudating into their retina. There are what we refer to as hard exudates. There are microaneurysms in their capillary vasculature. These are signs that their diabetes is out of control. And then we'll say, I'm glad that your A1C was normal. Would you mind going back to your doctor and mentioning that we see direct evidence of problems with your microvasculature? And it's probably all over.
And how did the endocrinologist receive that news?
Yeah, typically they will accept it. They'll say, okay, well, for this individual, that level of A1C is not acceptable.
Yeah, yeah.
And they've been typically very receptive because, they know we can directly visualize.
I mean, look, this is sort of my soapbox, but I really think that ophthalmology should be more integrated into medicine than less, because you guys do in some ways operate sort of outside of what the surgeons and the internists and the endocrinologists do. Obviously, here's an example of where you're kind of saying, look, I'm seeing something and it's important to your systemic health. I think there should be more of an integration of this. I think, again, you said it earlier, and I think people might not have appreciated what you just said. You get to directly look at the brain. You get to directly look at the central nervous system in a way that a gastroenterologist can directly look at the colon. Right. That's why colon cancer screening is so freaking effective.
Yeah.
You get to look with the naked eye directly at a polyp as it becomes cancerous.
That's one of the reasons I didn't become a gastroenterologist.
And we are thankful for them because of all they can save us from.
Absolutely. No doubt. No doubt. So, but it is amazing that we have the ability to directly observe brain and the vascular tree. And so that's very, very helpful.
Well, Stephen, this has been super interesting to me. I was a little intimidated coming into this one because I didn't have the amount of time I normally have to prepare for this and try to get up to speed on the topic. So I came in blind and ignorant, but you did a masterful job of accommodating my ignorance. And I learned a hell of a lot, and I'm sure everybody else did.
Well, thanks for having me, Peter. I really appreciate it.
Thank you for listening to this week's episode of The Drive. If you're interested in diving deeper into any topics we discuss, we've created a membership program that allows us to bring you more in-depth, exclusive content without relying on paid ads. It's our goal to ensure members get back much more than the price of the subscription. Now, to that end, membership benefits include a bunch of things. 1, totally kick-ass comprehensive podcast show notes that detail every topic, paper, person, thing we discuss on each episode. The word on the street is nobody's show notes rival these. Monthly AMA episodes or Ask Me Anything episodes, hearing these episodes completely. Access to our private podcast feed that allows you to hear everything without having to listen to spiels like this. The Qualies, which are a super short podcast that we release every Tuesday through Friday, highlighting the best questions, topics, and tactics discussed on previous episodes of The Drive. This is a great way to catch up on previous episodes without having to go back and necessarily listen to everyone. Steep discounts on products that I believe in, but for which I'm not getting paid to endorse. and a whole bunch of other benefits that we continue to trickle in as time goes on. If you want to learn more and access these member-only benefits, you can head over to peteratiamd.com/subscribe. You can find me on Twitter, Instagram, and Facebook, all with the ID Peter Attia MD. You can also leave us a review on Apple Podcasts or whatever podcast player you listen on. This podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Finally, I take conflicts of interest very seriously. For all of my disclosures and the companies I invest in or advise, please visit peteratiamd.com/about, where I keep an up-to-date and active list of such companies.